¿Qué es Promosalud? Promosalud ofrece recomendaciones de aplicación en la clínica dental para la detección precoz del riesgo de padecer diabetes o hipertensión arterial. En España, 17 millones de personas padecen hipertensión arterial y 5 diabetes. Prácticamente la mitad de estos pacientes no están diagnosticados. La consulta dental es un espacio sanitario que recibe la visita del 60% de la población al menos una vez al año. Esto confiere a la asistencia odontológica el potencial para mejorar la calidad de vida mediante la promoción de la salud bucal y general, contribuyendo así al Objetivo 3 de Salud y Bienestar promulgado por Naciones Unidas dentro de los Objetivos del Desarrollo Sostenible marcados en la Agenda 2030. Los objetivos de Promosalud son 3. 1. Prevenir, diagnosticar y tratar las enfermedades periodontales de los pacientes. 2. Sensibilizar a la sociedad de la importancia de la periodontitis como indicador de riesgo de la diabetes mellitus o enfermedades cardiovasculares. 3. Detectar el riesgo de padecer prediabetes, diabetes mellitus o hipertensión en las personas que reciben atención odontológica en las consultas dentales. La Fundación SEPA pone a disposición de las 23.500 clínicas dentales españolas Promosalud una herramienta de aplicación clínica que, bajo la dirección del dentista, permitirá al equipo de salud bucal contribuir a mejorar la calidad de vida de la población. SEPA, periodoncia y salud bucal para todos.
Good afternoon. Welcome to this symposium of the Spanish Society of Periodontology about a very relevant topic, Promosalud. The speakers will now try to explain to you how it works, although many of you already know about it. We're going to have a very dynamic program. You can read on the screen the name of the speakers, and we're going to first talk about the origin of Promosalud, which is this project we're talking about. Secondly, since Promosalud basically deals with the detection of high blood pressure and diabetes mellitus in the dental office, in patients who are not aware of their disease, we're going to invite and have two top speakers. Dr. Eva Muñoz Aguilar is going to talk about cardiovascular disease and the association between periodontitis and high blood pressure. We're also going to have Dr. Praveen Sharma. By the way, we're very thankful for him to be with us. He is a very well-known expert on diabetes and the association between diabetes and periodontal disease. Next, we're going to have Dr. Antonio Lorente, who is very expert on Promosalud. Lorente, who has a lot of experience and in Promosalud, he's going to tell us about the step-by-step way to do in Promosalud. We are going to talk also about the promotion of healthy lifestyles from the dental office. Mario Narce is going to talk about that. And finally, Eduardo Montero, the professor, is going to talk about the results that we've been collecting up to now with the Promosalud project. So it's going to be a very good result eventually, little by little, that prove how relevant the dental offices are to prevent systemic diseases, as we told you, and hypertension. This wouldn't be possible without the collaboration and the sponsorship of the DENTAID lab. Certainly, we're very thankful for their efforts. It is extremely important, and obviously that's what we need to do. Without them, we would not be able to develop a national project and probably also in a very few months at an international level to promote healthy in dental offices. So I'm going to give the floor to Dr. Patricia Anton, who has a degree in pharmacy and she has a degree in health, and she's the person in charge in the medical area of dentate. So, Patricia, thank you so much for the Spanish Society of Periodontics and the dentists. Thank you for being here in this project, and I'm going to give you just a few minutes to talk to us. Thank you, Miguel. First of all, I would like to say that good afternoon to everyone who is listening to us. It is such a pleasure to be here today representing Dentate to start together with Dr. Miguel Carasol this first Promo Health Symposium so that we can reach professionals from different countries. Promosalud, as we saw in the video, is an pioneer, innovative project promoted by the Spanish Society of Periodontics with the strategic support of Dentate. For us, Dentate, to be part of this project together with SEPA is a proof of how we promote the efforts of professionals so that all of us together improve and promote the oral health of people. The objective of Promosalud, as we've already seen earlier, is clear: promoting prevention, diagnosis, and treatment of periodontal diseases on the one hand, making society aware on the other hand of how important periodontitis is as a risk factor for diabetes mellitus and cardiovascular diseases also. And also, we want to detect the risk to suffer diseases such as prediabetes, diabetes mellitus, or diseases such as blood hypertension in people who go to a dental office to get dental care. It is a project that promotes the general health of people from the dental office by promoting also the role of the professional care in the dental office in order to do the early detection of these very important diseases, diabetes mellitus, and the cardiovascular diseases such as blood hypertension. We shouldn't ignore that in dental offices, we get around 55% of the population at least once a year. As of today, we can state that we already have a total of 2,000 dental offices that have adhered to this project. These 2,000 dental offices have added 1,000 patients in this screening. And also with these sessions, we hope that there's going to be even more offices that want to adhere to this project so that this initiative gets better and larger. With Promosalud, we want to position dental offices as a key link in the health chain so that the society is more and more aware of how important periodontitis is as a risk factor for systemic diseases, because as we all know, there's a direct relationship between oral and periodontal health. Therefore, this symposium is a very special opportunity to get to know much better and in detail the relationship between periodontal health and systemic diseases. And therefore, without further ado, I'm going to give the floor to Miguel Carasol, who is going to introduce the rest of the speakers. And for sure, we're going to learn a lot from them all this afternoon. Thank you to all the attendants also. And on behalf of Dentaid, I'd like to especially thank SEPA for the great initiative. Thank you, Patricia. Thanks to Dentaid once again, and to you because of the big effort that you're making with Promosalud. We've been working together for years, actually, yes, many years promoting this lovely, wonderful project, and your initiative and your enthusiasm is great. Thank you so much, Patricia. Thank you, Miguel, and thank you, SEPA. I'm going to very briefly present some slides about what is the origin of Promosalud, what is the reason, the raison d'etre of Promosalud. We've realized that in the dental office, we see millions of patients actually, and fundamentally what we do somehow is that we treat the oral problems, obviously. Okay? And within these oral problems, you know, periodontitis is one of those diseases that we as periodontists, like me, consider that it is a very, very important disease. It's a non-communicable disease, one of the most important ones in humans. It affects almost half of the world population. There's more than 100,000 of people with advanced ways of periodontitis. It's incredible. And if we talk about this, in Spain, in studies that have been made by our research group, we've concluded, actually, we have proven that 38% of adults in working age suffer from periodontitis, and that increases prevalence of periodontitis increases with age, so that 60% or more of people over 55 years suffer from periodontitis. And this is a hugely relevant number. Especially relevant is the fact that only 5% of the population is considered periodontally healthy. Why is it that we're talking about periodontitis? Because periodontitis is not a disease that destroys locally the oral cavity, the teeth, or the gingiva, but rather there's two reasons: the aggression of pathogens on the one hand, and systemic inflammation that is caused by this chronic lesion of low degree, that is to say, it affects constantly, little by little, all the tissues and bodies and organs of the body. To the right, you have a case of an ulcer in a diabetic patient who suffers also from periodontitis. That does not mean that periodontitis causes this, but it is a risk factor that contributes once again to the systemic process. So we're getting outside of the oral cavity, and to this we call medical periodontics or periodontal medicine. And actually, two of the most relevant diseases where the periodontal diseases associated are mellitus diabetes type 2, basically, and cardiovascular diseases, arteriosclerotic one. What does this mean? That we in our dental offices are very good at treating restorative pathologies, aesthetic pathologies, periodontal pathologies by detecting that we even need to detect even more brain problems and many other things, oral diseases. And this is important because up to recently, the image on the right is very important because it says only teeth, you wait here. That is to say, we were used to treating boxes with gingiva and teeth, but those boxes with gingiva and teeth belong to people, and those people can be ill or maybe not. And also, the bucco-dental situation, especially the periodontal situation, can have an influence on the systemic situation of the patient. That was the origin of Promosalud. It is to promote health. It's self-explanatory. In dental offices, we don't only focus on the mouth, we focus on the patient as a whole, systemically. Okay, this is an initiative that promotes buccal health and general health. That's an initiative of SEPA, of course. That facilitates the early detection, in this case, of the risk of suffering from two very important diseases for the human being, such as diabetes mellitus and or blood hypertension. That is to say, very prevalent diseases with complications of morbidity and mortality, very important ones actually, that can be diagnosed or detected early. That is why we created Promosalud. And this is not an idea that we've developed ourselves by ourselves alone. No. It's backed by the Spanish Society of Cardiology, the Spanish Society of Diabetes, the Spanish Society of High Blood Pressure. It's also backed by the Council of Dentists. It's part of the Alliance for Periodontal and General Health of SEPA. And also, as we've explained, it has the fundamental support of DENTAID. Good. Why is it that Promosalud is important for a dental office? Well, easy. Look at the evolution of a dental office, of the patients that go to a dental office for 2035, which is going to be in only 10 years, believe it or not, we're going to see a decrease of natality. That's what we're seeing, actually, right? There's going to be a reduction of the amount of young patients between 30 and 50 years, and the high part of the average age population, all of us who are older than 50, it's going to grow a lot, our part of the pyramid. So 25% of all of the patients who go to a dental office will be older than 64. And that means that there's going to be 37%, 38% more almost of patients or people with an age
of over 64 years of age. What does this also mean? That these patients who are going to come to the office also suffer because of their age, one at least or even more chronic processes, so that 70% of people over 65, as we will see, will come with more than one chronic disease. And many of them are called chronic complex patients because they will suffer from up to 4 chronic diseases. It's not difficult for them to have it, such as cholesterol, high blood, hypertension, diabetes mellitus, lumbalgia or backache, and so on. So, unfortunately, as we're aging, we're facing the fact that the population is older. There's a growing percentage of chronic diseases, and we will see them in the patients that we serve in our dental offices. But also, as we've seen, there is going to be a high prevalence of periodontal diseases, and the periodontal disease per se can be associated to systemic pathologies such as diabetes and blood hypertension. So, what is it that we have in our dental offices? It's an opportunity to screen rather than diagnosis, because we dentists don't diagnose, but we screen. We assess the possibility of maybe referring them to a doctor so that he or she diagnoses a possibility that we screened. The two important ones that we focused on are diabetes mellitus and blood hypertension. Why? Because look at the left. Diabetes mellitus is suffered or used to be suffered in Spain. Maybe now it's even more, almost 5.5 million people, out of whom almost half don't know that they suffer from diabetes mellitus. Diabetes mellitus is a multi-organic disease that takes between 5 and 10 years to show the signs, and the consequences in terms of morbidity and mortality are very important. That is why if we were able to screen, to refer patients that we suspect could suffer from diabetes to the doctor years before they have these complications. Actually, periodontitis is number 6 nowadays complication of diabetes, and therefore we would be really shortening in many years the probabilities of complications and the mortality. We would be saving lives. What happens with blood hypertension? It's even worse. We know today that people over 18 years of age, 10 million suffer from blood hypertension, out of whom, and this is a problem, 20-some percent, 30-some percent don't know that they suffer from high blood pressure, HPP. So, dental office is an element, is a very important element to detect these diseases, to value the risk of suffering them. Why in the office? It's easy, because look at these very relevant numbers. In 2021, there was a study by the Council of Dentists in Spain that concluded that 55% of the population of people from between 20 and 78 years of age went to the dentist in Spain regularly, actually. Another very relevant fact is that many patients go to the dentist, but they don't go to the doctor. Why don't they go to the doctor? Because they don't only go to the doctor when they face pain, infection, trauma, and so on, acute situations. But it's not because they just want to do prevention. What does this mean? That many patients don't know that they suffer from chronic diseases or the risk of suffering from them, especially young adults. And there's diseases such as diabetes and especially blood hypertension start to manifest their first signs and evolve in a silent and chronic way from the time you are a young adult. Is there a potential to value the systemic risk? Oh, yes, Patricia explained that already. There's more than 40,000 dentists in Spain, more than 23,600 dental offices. Nowadays, really, we have a lot of offices that are adhered to the Promosalud project. It is a huge project that we're not only developing in Spain, but also we're going to introduce in countries internationally. In the next week, actually, Eduardo Monte and myself are going to present it in Mexico online, and this is very relevant. Why is it that the dental office is important? Well, look, screening, that is to say, assessing the possibility of a patient suffering from diseases such as diabetes and high blood pressure, it's very important for dental offices. We do not diagnose, I insist, we just screen. We don't adjust the treatment dosages, but we are very relevant in monitoring our patients. Why? Because somehow we see our patients periodically, more or less, especially periodontal patients. That is to say, we cannot justify the fact that a dental office is not going to want to screen blood hypertension or diabetes mellitus because science backs that. So this is very important. This is one of the ads, commercials that we have in Promosalud. 5 minutes with your dentist can save your life. It seems an exaggeration, but it is not really, because high blood pressure specifically is called the silent murderer or killer because it does not have issue signs that warn you. So it is important to prevent the strokes and so on. And this is an introduction of what we're going to see. And we're going to now focus on two of the systemic diseases that are most relevant, included in Promosalud. Number one, we're going to talk about periodontitis and cardiovascular pathology, especially the association and screening of blood hypertension in the dental office. And for that, we've invited Dr. Eva Muñoz Aguilera, who is an extraordinary person, but she's also one of the leading authorities in the association between periodontitis and high blood pressure. She got a degree in dentistry in Granada University, but then she moved to the UK, right? And over there, she was a member of the Dental Surgery College, the Royal College of Surgeons of Edinburgh, and she did a master's program in periodontology and in implant dentistry in the Eastman Dental Institute. She has a certificate also of membership of the European Federation of Periodontology. She has a certificate of the Royal College of Surgeons of Edinburgh, and so on. She's a PhD in dentistry. I was lucky to listen to her presentation, her dissertation of the PhD, where she got an extraordinary award, and she also has a private office in periodontology and implant dentistry in London, and she's a member of IT, SEPA, and many other societies, but well, she's also part of the Community of Alliance for Health, which is what we like to call the community of the ring. And she's the coordinator of the group composed by the Spanish Society of Cardiology and the Spanish Society of Diabetes, I think he said. She's a very relevant person. Thank you, Eva, for being with us, and she's going to talk about what she knows about. Thank you. Thank you very much for your kind introduction, Miguel. I'm going to share my PowerPoint, if you allow me. 1 second.
¿Se ve ahora?
Can you see it? Yes.
¿La vemos la presentación?
Can you see the presentation? Yes, we can. Yes, Eva, thank you.
Vale, pues como decía, muchísimas
Good.
gracias por
Thank you so much, as I was saying, for your introduction. Thank you so much for the invitation to participate on in this project. It is such an honor for me. You've got me involved from the very beginning. The objectives of Promosalud are clearly aligned with mine personally, because they involve the promotion of the treatment of periodontal diseases, prevention of risk factors, and the fact that we can intervene systemically is important. We dentists have that possibility in our offices, as you explained rightly.
Sí, Eva, a ver si puedes poner la pantalla completa, por favor.
Exacto, eso iba a
I'm
hacer.
having a little issue with sharing the full screen. Okay, now there we go.
Pues lo que
Yes.
por mi parte, lo
Okay.
que me toca es
Well,
hablar un poco de la
I'd like
relación
to
o
talk
actualizar
about
las
the
relaciones diagnóstico y la
relationship
patología
between
cardiovascular
periodontitis
y el
and
por qué la
blood
importancia de este cribado de
cardiovascular pathology
hipertensión
and see the
dental, aunque
importance
ya lo
of
habéis
screening in the dental
descubierto bastante
offices.
bien
You've
por
talked
el
about that,
momento.
though,
¿Qué
quite
podemos
well.
saber de las enfermedades
What can we
cardiovasculares?
know
Bueno,
about
como hemos
cardiovascular
comentado anteriormente,
diseases?
son
Well,
una
as
enfermedad crónica
you've said,
de
it's a
etiología
chronic
diversa, multifactorial,
disease
que
of
involucran
multifactorial
cardiomiopatías, arritmias,
diverse
enfermedad
etiology,
isquémica,
including
enfermedad
ischemic disease,
periférica, que como hemos comentado
cardiopathy,
anteriormente, son la primera causa de
cardiomyopathy,
muerte a nivel mundial.
arrhythmia, and
El
peripheral
32% de las
disease.
muertes que se producen en el mundo son
32%
debidas
of
a esta patología.
deaths in the
Consecuentemente,
world are due to this
las
pathology.
personas
One
que mueren,
third of people who
mueren
die
a causa
die
cardiovascular, o sea que es una
for a
relevancia
cardiovascular reason.
asombrosa.
So it is
El
extremely
40% de
relevant.
esta mortalidad está
45% of
asociada
this
a enfermedades
mortality
no
is
transmisibles.
associated to
Es decir, de todas aquellas
non-communicable diseases.
enfermedades que
That
nos
is to say, out of
transmiten
all of the diseases that
respiratorias,
are
el
not
50, prácticamente el
communicable,
50% de esta mortalidad
50% almost
es
of
de
that
causa
mortality is
solamente
caused
cardiovascular.
by a
Pero
cardiovascular
la
disease.
pena es
But
que
it's
son
a pity
enfermedades que en
because
cierta
these
manera se pueden
diseases
prevenir,
somehow
como
could be prevented
atajando ciertos factores de
if we
riesgo como el
shorten some risk
tabaquismo, la
factors
dieta, la
such as
obesidad, actividad
smoking,
física,
diet, obesity,
sedentarismo,
physical
etcétera, etcétera. El
activity,
principal factor de riesgo
sedentarism,
de
and so on. The
enfermedades
main risk
cardiovasculares
factor
es
of
el hipertensión
cardiovascular
arterial
diseases is blood
y por lo tanto
hypertension.
tenemos que
And
ver
therefore,
por qué
we need to
podemos
see why
tener una buena
we
intervención
can
en lo que
have a good
está
intervention
en
as
este campo.
dentists in this field.
¿Qué ha ocurrido? Bueno, pues por
What
desgracia
has
la
happened?
prevalencia de las
Unfortunately, the
enfermedades
prevalence of
cardiovasculares a nivel
cardiovascular
mundial no ha
diseases
hecho más que
globally
aumentar.
has been
Desde
growing and growing. From
1990 hasta
1990 to
2019 prácticamente se ha
2019, it's
duplicado
been
de unos
doubled almost, more than
270 millones, ha subido a
270
500 millones.
million
Y
to
en consecuencia la mortalidad ha
2020.
subido más
So
de
the
un
mortality
tercio.
rate
Es
has
decir, que en vez
been
de
doubled or
evolucionar
increased more
y
than two
intentar
thirds.
mejorar,
Instead of
vamos un
evolving
poquito
and trying
peor
to improve,
debido
we're
a los
getting
factores
worse and worse
Miguel ha puesto
because
de
of the
ejemplo, ¿no?
factors
Que
that
tenemos una
Miguel
población cada vez más
explained. We have a
envejecida
population which
y
is
bueno, hay
older and
cierta, hay un
older,
montón de países que por
and there's
desgracia
many
todavía
countries, unfortunately, that
no
are
tienen un
still
soporte
not having
importante para
an
atajar este
important
tipo de
support
patologías,
to a
pero en
way
los
to
países, digamos, desarrollados
cut short these
tenemos una
pathologies,
de las
but we developed
principales
countries have one of the
causas de
main
muerte.
causes of
¿Qué
mortality.
ocurre con la hipertensión? Bueno, pues
What happens with
vemos,
high
como
blood
hemos dicho,
pressure?
que
Well,
actúa
as
asociado
we've
al riesgo de
seen, the
enfermedad
main risk
cardiovascular,
factor
sobre todo
of
enfermedad
cardiovascular
cardiovascular
disease,
aguda.
especially
Lidera las causas
acute,
de muerte en más de 10
leads
millones de
the death
personas mueren
causes
al
in more
año
than
y
10 million
92
people
millones
a year die a year, and
de
92
años
million
debido a
of
circunstancias
years
de
of
discapacidad. Es
life
decir, causan
adjusted by
mucha
disability.
morbilidad.
So it
Y
causes a lot
tenemos
of
también la
morbidity.
enfermedad
It
cardiovascular
increases
aguda,
the
como es el
cardiovascular
miocardio o el
disease
ictus.
acute,
Son
such
enfermedades
as
silenciosas, como ya se ha
myocardium
dicho anteriormente,
infarction
que
or
no se da uno cuenta de
stroke.
que
They're
tiene una
silent
hipertensión hasta
causes.
que
You don't realize
probablemente
that you
causa un
suffer
ictus
from
hemorrágico
hypertension until
o
you
un
have a
infarto o
hemorrhagic
una arritmia que
stroke or an
causa un
infarction,
desajuste a
or
nivel
suddenly
sistémico.
you just have a
Y la
systemic
enfermedad de la
misadjustment.
hipertensión
And
pues
the
también es
high
muy, muy,
blood
muy
pressure
relevante porque es muy
disease is
prevalente. Más
very
del
prevalent and
33% de los
relevant. More than
pacientes adultos
33% of
entre
the
30 y
global
79 años
population of adults between
sufre,
30 and 79 suffer from high
esta
blood
enfermedad.
pressure.
En España, como
In
comentaba Miguel,
Spain,
más de
as
46.000
Miguel said, more than
muertes al año están
46,000
asociadas a la
deaths a
hipertensión.
year are associated to high blood pressure.
¿Qué podemos decir en cuanto a su
What can we say
definición?
about
Bueno,
their
y
definition? Well,
definiciones tenemos muchas,
we
dependiendo de la
have many
sociedad
definitions depending on the society,
internacional o de las guías
the
a las
international
que estemos sujetos.
guidelines that
Los
we
niveles de presión
subject to.
arterial que vemos aquí ahora
The
mismo,
blood pressure
si
levels that
requiere
we see
presión
right
arterial
here are
sistólica de más de
describing
140
systolic
o
blood
diastólica de
pressure
más
of
de
more than
90. Esto
130 or
en la mayoría de las
diastolic
sociedades
of more than
coincide. Sin
140. That's
embargo,
something
podemos
that
ver
most of
que
the
una
societies
presión
agree
arterial
on.
normal
But normal
puede
blood
ser menor a
pressure can
130
be under
y de diastólica
130
menor
and
de
diastolic
65.
under
Sin embargo, la nueva
85.
sociedad,
But the new
nueva guía de la
guidelines
Sociedad
for
Española
the
de
Spanish Society
Cardiología,
of
de Europea,
Cardiology,
perdona,
or
nos
the
muestran
European rather,
que aunque
prove that
la
even if
definición de
the
hipertensión
definition of high blood
se
pressure
mantienen los mismos valores de más de
keeps the same
140
values, more than
sistólica, 90 de
140
diastólica.
systolic and
Si
90
os
of
fijáis,
diastolic. If you
la
look
presión
at
arterial
the
elevada
blood
ya se
pressure,
sitúa en
elevated
unos
blood
valores entre
pressure
120 a
has
139, es
values of
decir, si tú
between
tienes
120
125
and 139.
de
If you have
sistólica
125 of systolic
o
or
75 de
75
diastólica,
of
ya estamos en niveles
diastolic,
elevados. ¿Y esto
we're
por qué
in
ha
high
sido? Se ha
levels. Why
demostrado
is
que
that the
a
case?
niveles
Because
más
it's been
bajos
proven that
de
at
presión
lower
arterial
levels of blood pressure,
empezamos a sufrir
we start
más
to
riesgo de
suffer
enfermedades
from higher risk
cardiovasculares
of
agudas. Por lo
cardiovascular
tanto,
acute
las
diseases.
sociedades están
Therefore, these
poniendo aquí en
societies are
riesgo cada vez valores de
risking
hipertensión más
values
bajos. Por
reducing the blood level values for risk. So the lower these values are, the more protected we will be. So we need to make sure that the high blood pressure does not get even higher. What data are important for high blood pressure? The global health, the World Health Organization showed that more than 46% of adults are not diagnosed. That's very relevant. 50% does not know that they have high blood pressure. 42% of those who know that they have high blood pressure are in treatment, only 42%. The majority, or rather the number that I am most impressed is that it seems that only 21% have high blood pressure under controls. There's a problem of some time. We have not solved this problem at all. In Spain, as Miguel said, 24% of treated people have not still got high blood pressure under control, and there's a lot of people who are not diagnosed yet. What's the good news? If we decrease the systolic and diastolic blood pressure between 10 or 5 mmHg, we have a very important reduction of the risk of a stroke, myocardial stroke, and so on. We can decrease mortality. Every degree of millimeter of Hg, we're going to help reduce the mortality and morbidity, but also we're going to reduce the health expense, which is an important consequence of the care load or burden of these diseases. We can save even 850 million of health expenditure in 10 years. That's important. What's the relationship between periodontitis and this? Well, as we've said, we have not controlled at all cardiovascular diseases, and we're looking for new risk factors that can be the cause somehow of the exacerbation of the consequences of cardiovascular diseases. New risk factors, we've seen that periodontitis is one of them. That's been proved by many medical and scientific societies. It's important for our efforts to be shared. We know periodontitis is a chronic disease, very prevalent, that affects aesthetics, the health, and our lives at large. We know that the most recent numbers are even higher than those we expected. More than 62% of the global population is affected by its more severe way, 12.5%. That's to say more than 1 billion. That's one of the most recent students by nacimiento that have been published recently. As we know, it increases the cost of the public health system, but we also know that we have to be interested in periodontitis because we discovered that patients with periodontal disease have inflammatory systemic markers higher than those patients who did not have periodontal disease. The consequences are that these inflammatory markers and immunologic disorders of these patients who suffer from periodontology have systemic consequences, as we can see on this graph, and I don't want to take too long in analyzing the association of the biology, but we know that those bacteria that we have in our bloodstream, in our in our mouth, go to the bloodstream, and the inflammation markers also. We know that there's a lot of effect nowadays on systemic diseases in terms of inflammation. Many of these diseases have the basis are based on inflammation, and these periodontitis cause low-degree systemic inflammation. C-reactive protein, for instance, can be increased in only 1 or 5% compared to what would be done by COVID, for instance, that can be increased up to 30 or 40%. Well, maybe it seems that's not important, but really having that effect throughout the life of the patient for many years chronically, it's proven to damage the organs. In the case of the cardiovascular pathology, it affects especially the vascular system, also the endothelium, rigidity, and the atheroma plate formation. What do association studies suggest? Well, when we see the studies of epidemiology in large scales, periodontitis is associated to endothelial dysfunction, arterial rigidity, thickening, and calcification of the walls of the carotid. This means that patients with periodontitis have a 15 or 30% higher risk of disease. Maybe that does not seem to be a very high risk, but if we consider that we have prevalence levels which are very high, we can understand that the effect is a clinic one and very important. Epidemiologic studies prove that periodontitis affect cardiovascular acute events such as cardiac coronary disease, ischemic stroke, peripheral artery disease, and so on. So we are at risk of dying if we have periodontitis, and we need to inform our patients. Hypertension and periodontitis. Well, we know that there's a relationship, clearly. I was lucky to work with a group of researchers in different universities, and there's many papers that show findings that we need to consider. We know that patients with periodontitis are going to have 70% more risk of high blood pressure. So it is an important risk factor for high blood pressure. Levels of more or higher systolic and diastolic can be increased in higher periodontal patients, and it's an average. But if we reduce to 5, maybe we can reduce the risk. We shouldn't underestimate the averages of higher levels of systolic or diastolic high blood pressures. Bleeding of gingiva per se is also associated to high systolic blood pressure. We don't need to get to periodontitis numbers to know that that proves inflammation that can be systemic, so that it increases the risk. As we said previously, we're going to have more inflammatory markers in our system if we have periodontitis than if we don't. And it is very important for the periodontal treatment, and I don't want to elaborate too much on this. It's proven to be important because it improves the metabolic system and the systemic inflammation and the endothelial rigidity. And there's studies that have been made that are serious and rigorous with a bigger sample and standard values, and it's been proven that we can reduce systolic and diastolic high blood pressure up to 10 millimeters. We don't have many studies that repeat this process. Right now, they're costly studies that cost a lot of effort, and therefore right now they're being done, so to say. And we know that there's patients that suffer from periodontitis and have a worse control of high blood pressure. That's important. If there's patients who come to our office with an infectious inflammatory problem in their mouth and they have high blood pressure, we need to tell them always that not having the periodontitis under control is going to be a higher risk of high blood pressure. This is an important survey that proves several things. Number one, it's a survey between cases and controls. The cases were patients with periodontitis, controls were patients who did not have periodontitis. All these patients were healthy systemically. And what we could observe is that the fact that they suffered from periodontitis, they had high blood pressure in patients with periodontitis, high risk of suffering from systolic high blood pressure of over 140. Gummy bleeding is associated to a higher high blood pressure, but it's very interesting, even if it's a secondary finding, not the main one of the study, but we saw that high blood pressure, which is not diagnosed, hypertension values was a casual finding, very common in between 15 and 45 patients of this study. Similarly, this study that we did in Portugal also showed that 15% of the sample did not have a diagnosis of the high blood pressure. That affected especially patients with periodontitis. So be careful when we do our screening. Possibly patients with periodontitis also have more hypertension, high blood pressure than those that don't have it. As Miguel said, why should we screen high blood pressure? Well, this initiative was shown in England. Well, we tried to make the society aware of the risk of high blood pressure. How can we do the screening of high blood pressure? Well, anywhere. In the workplace, in the supermarket, opportunistic screening in pharmacies, in medical offices, obviously, and obviously we should promote healthy lifestyles. And this never included dental offices. They ignored us somehow. And in this case, we need to also see that there's other initiatives, such as the ones that we see here of the main mission month, that has screened in more than 100 countries, more than 6 million people, where in May, measure month, free of charge, they've screened the high blood pressure, and they've discovered that over 1 million people out of the 6 million that were screened suffered from high blood pressure. So these initiatives are also effective in screening this problem. And other initiatives were seen in the United States also. People from ethnics, Black African, for instance, did not go in general to the dentist or to their general practitioner. And they discovered an initiative where in barrow shops, in hairstyle places, with the help of pharmacists, they could detect and reduce high blood pressure in this sector of the population. So we thought that we could also join this effort and help these initiatives. This is a study we did in Eastman. It has not been published yet, but it was part of the master's final project of students of hygienists and periodontologists. And they saw that when they do a periodontal chart and a record of high blood or of blood pressure in a tripled way, according to the clinical guidelines, we could see that if we include people over 18, and we want to see the prevalence of systolic or diabolic high blood pressure of more than 140, we could observe that 50% of them already had this blood pressure. More than 1,000 participants were included, which proves that it's a large sample. And in this case, we could see that there were 8 hygienists and 8 dentists. The screening can be done even by health professionals who work in the dental office. And as an average, we can see that the effort was rooted in the same way, so we can detect this problem in our patients. Out of all of these who had high blood pressure, more than 30% of them were in numbers of hypertension. Once again, this agrees with the general numbers of the population. Another study also, screening high blood pressure at dentist office. Once again, these values are the same. They're consistent, which indicates that if there's many studies that show the same values, the same levels, it makes sense the fact that we in dental offices can make efforts. 63% of patients previously diagnosed with high blood pressure were not under control. And once again, this agrees with the numbers of the World Health Organization. And some of them are just not taking the treatment, so we can do the screening. But we can also have the opportunity of somehow making our patients aware, since they come to our office more often than to the medical office. We can insist, have you taken your high blood pressure medicament and so on? We're health professionals, we have the opportunity with these objectives or with these initiatives of Promosalud within a regulated framework and backed by the scientific societies, that we can improve the health of our patients. We can also do a screening of a possible cardiac arrhythmia just by measuring the pulse. And we can see whether the pulse is a normal rate or not. We can suspect an heart arrhythmia, fibrillation articular, and this makes sense in patients of over 65 years. This is a measure that can be done easily in the office. Many of the devices that measure blood pressure can detect it as of today, and it adds one more step to improve cardiopathy problems. What are the conclusions? And I don't want to take longer. Periodontitis increases the risk of hypertension and cardiovascular diseases, acute and chronic both, systemic low-grade inflammation, and bacteria and aggression are biologic mechanisms that back these associations. It seems that the mediations between hypertension and high blood pressure is mediated with systemic inflammation. The treatment is going to improve the metabolic control and the systemic systemic inflammation and the endothelial function. We need to take into consideration that the early diagnosis and the control of risk factors are essential to improve the general health and also to decrease the care. And we also know that oral health professionals with Promosalud have the opportunity of having a more active role, getting more involved in the detection of hypertension with the consequences which are very important, cardiopathies and hypertension, for instance. And without further ado, I'd like to thank once again the invitation to be part of this very interesting project. Thank you so much, Dr. Muñoz Aguilera. It is always an honor, Dr. Muñoz Aguilera, to listen to you. It proves how much you've been working for many years with enthusiasm. And I think that the topic of hypertension is extremely important. I'm fascinated by it, at least. The relationship with periodontitis and hypertension is very important. There's many things that you've talked about, but it is very relevant, I think, to consider the fact that the screening of high blood pressure in a dentist office is not just something that the dentist needs to do, it's the entire team, the dental teeth hygienist also. So I think it is absolutely essential, this contribution that you're making, also proven scientifically. So thank you so much for your very serious participation in this topic. And let's go now to another very important Promosalud topic, which is diabetes mellitus. And for that, we have invited a leading speaker, a wonderful professional, Dr. Praveen Sharma. Dr. Eduardo Montero is going to introduce him. He's also a leading expert on the topic. So you have the floor. Thank you. Thank you so much, Miguel. It is a pleasure to introduce to you Dr. Praveen Sharma. Allow me to please go into English so that I can present or introduce him. Because Praveen is going to talk in English, so we're going to afterwards translate the talks into English, because the idea is for this webinar to be part of the international movement that Miguel was talking about in the project Health Promosalud, so that we can carry it out in different countries.
Praveen understands what I'm saying. Dr. Sharma, he's an associate professor in periodontology and restorative dentistry from the Dental School of the University of Birmingham, and he has published extensively on the field of periodontal medicine, particularly on the relationship between periodontitis and chronic kidney disease, but also he is involved in research projects related with the screening of different chronic and non-communicable diseases and conditions on the dental setting. And also it's a pleasure from the personal point of view, because I met Praveen already 10 years ago. But that time we were both struggling with our PhD. I met him in Birmingham, and it's a pleasure. You are going to enjoy a lot from Praveen. He's extremely brilliant. He's a brilliant scientist. I mean, he's not proficient just from a clinical point of view, but he does his own statistics. He's an specialist in big data and everything. So, Praveen, the stage is yours. Please go ahead with your presentation. And thanks for everything.
Thank you very much, Eduardo. It's lovely to see you again. And thank you for reminding me it's been 10 years that we've seen each other. Let me just start by sharing my screen. There we go. Okay, so thank you very much for the invite to the organizing committee and to Promosalud. I'm a bit of an imposter here because firstly, Spanish isn't a native language to me. So I had to quickly Google Translate the previous two speakers so I could understand. I could follow most of the talks, but it was good to kind of know what was going on. And secondly, because I'm stepping in at short notice for a colleague of mine, Professor Dietrich, who was originally scheduled to speak on this talk. So please forgive me if I've done this disservice. As Eduardo mentioned, my name is Praveen. I'm an associate professor and honorary consultant at the University of Birmingham here in England, and I've been asked to talk about screening hyperglycemia in the dental office and whether this is feasible or not. Just by way of housekeeping, throughout the presentation, you'll find little QR codes at the bottom right-hand corner for resources that I'm pulling my presentation from. These are all open access, so you can feel free to take a photo with your smartphone and access the link that way. And when it comes to questions, you can obviously ask questions at the end, but if you feel like that's not a format that you're comfortable with, or if you can't think of a question or you think of a question later on, you can always contact me via email or on social media. So either of those are fine as well. Brilliant. So let's dive straight in. So by way of background, I don't need to stress to this audience the importance of diabetes as a disease. Diabetes is very prevalent. About 1 in 10 people around the globe, adults around the globe, have diabetes. The prevalence is slightly higher in Spain at approximately 15%. It has significant morbidity and mortality associated with it, and mortality comes from direct consequence of diabetes, but also indirectly by affecting other diseases like Eva was talking about, cardiovascular disease and chronic kidney disease, which is what I did my PhD in. And the main thing is that 4 in 10 people who have diabetes are unaware that they have diabetes. And this is why screening for diabetes is an important thing, because 40% of the people who have diabetes are not aware that they have diabetes. So finding these patients, diagnosing them earlier, managing their disease earlier is obviously beneficial for their health and for the healthcare in general. Miguel touched on this earlier, the mechanistic links, and Eva did as well, the mechanistic links between periodontal disease and systemic diseases. So I just want to briefly mention the mechanisms here again, just from a first principles, very easy to understand way. So gingivitis and periodontitis both lead to a breakdown in the sulcular epithelium. This is the epithelium that lines the sulcus, the gingival sulcus. It's most adjacent to the bacteria on the tooth and root surface, and those bacteria lead to local inflammation and cause little micro ulcers in the sulcular epithelium. And this photograph was kindly lent to my mentor, Professor Chappell, by one of his mentors, Steve Offenbacher. So I use it all the time in my presentations, and thank you very much. The breakdown of this epithelial continuity, the breakdown of this epithelial barrier, then allows for the ingress of bacteria or bacterial products or spread of local inflammatory products to the systemic circulation. And this, coupled with the translocation of bacteria from the oral environment to the gastric environment, are thought to be how periodontal health, oral health, affects systemic health. There are some disease-specific mechanisms, but these are where they stem from in general. When it comes to the often quoted bidirectional relationship between periodontitis and diabetes, we know that patients who have diabetes who don't have periodontitis are at an increased risk of developing periodontitis. And if they develop periodontitis, then they generally have worse inflammation. And I'm sure the clinicians in the audience will know this instinctively, that there is a particular phenotype of periodontitis that goes with poorly controlled diabetes or undiagnosed diabetes. Patients with periodontitis who don't have diabetes are more likely to develop diabetes. And in patients with both these diseases, then both diseases are made worse by their co-occurrence. So your periodontitis is made worse if your diabetes isn't well controlled, and your diabetes is made worse if your periodontitis isn't well controlled, well maintained, if your periodontal health isn't well maintained. We know that for patients who have diabetes and periodontitis, then the treatment of periodontitis leads to a significant reduction in HbA1c. HbA1c is a glycated form of hemoglobin, which is a marker of sort of medium-term glucose control. Extra glucose in the bloodstream reacts with hemoglobin to create glycated hemoglobin. So over time, you can measure levels of glycated hemoglobin, which give you a much more stable, much more medium-term window into glucose levels, which can fluctuate quite wildly, even within a day. And in terms of the magnitude of effect, the reduction in HbA1c from periodontal therapy is equivalent to adding a second drug to a metformin regime. And again, the clinician amongst the audience would recognize metformin as a drug that is used to manage diabetes. If to a metformin regime you add another drug, the reduction in HbA1c is comparable to if you manage someone's periodontal disease. So the benefits are huge, and they're non-pharmacological. So you don't have any of the pharmacological side effects, the risks that come with taking a medication. You're managing your disease by improving your health, which is a real plus for our patients. So the thing I was asked to talk about was screening for diabetes in a dental setting. So there's some positives. The dental screening is often used, the dental setting is often used for screening. We screen for things like periodontitis. We screen for things like oral cancer. We screen for things like tooth wear. So we're very used to, as clinicians, screening for diseases. The dental setting is also a healthcare environment, and that's really important to understand. Eva mentioned a study earlier where healthcare messages were being delivered in a supermarket, were being delivered in a barber shop. And those environments are great because then you find different populations, but the reception of healthcare from those environments is very different. And you can use this as your own example. If you were stopped in a supermarket by a 17-year-old employee at the supermarket who said, "Can I weigh you? Can I check your blood pressure?" How would you respond compared to if you went to the dental surgery and your dentist said, "Can I weigh you? Can I check your blood pressure?" So you're much more receptive because you're in that environment. As a patient, you're much more receptive to the healthcare message that's being delivered along with the screening. So it's not just that the screening is being done, it's what's happening after the screening is being done. Does the screening lead to a diagnosis? Does the diagnosis lead to behavior change? Does the behavior change or management, does that lead to improved outcomes? So screening is just the start of that very long journey for a patient, and that is much better delivered in a healthcare environment. A dental setting is often places, settings where invasive procedures are undertaken and healthcare advice is given. So if your screening test, like for diabetes, involves a finger prick test, which is slightly invasive, in a dental setting, that's very common to happen, right? It's not a big step up to have a finger prick test done at a dental setting. And we're used to, as again, healthcare professionals delivering healthcare advice. We used to talking to our patients about smoking. We used to talk to our patients about alcohol consumption, about weight management. We're used to giving advice and hoping that our patients change their behavior. So again, as a setting, the dental setting is primed to screen for patients with diabetes. And as Miguel mentioned, different populations see different healthcare professionals. So some people will go to the doctor when they're unwell, but a lot of people will go to the dentist even if they don't have any problems. And this is the key thing about screening in a dental setting, is that you're going to capture a different population to if you screen at the doctor's or if you screen somewhere else. Patients come to us even when they're well, and that's a really good opportunity for us to screen and improve their overall health. So when it comes to screening for diabetes in a dental setting, what does the public think about this? So the public, when we did a survey, had a resounding yes to this message. In the survey that we conducted, over 60% had attended a dentist, or at least said they'd attended a dentist in the last 6 months. And of those, almost half hadn't had any dental checks, any medical checks from their doctors in that period. So the public support for screening for medical conditions in a dental setting is strong, about 75% in our survey. And this screening was most readily accepted for diabetes and cardiovascular disease. So what do healthcare professionals think about screening for diabetes in a dental setting? And again, the results from our survey were a resounding yes. Doctors, dentists, and pharmacists are all in favor for dentists to screen for diabetes in a dental setting, or chronic diseases in a dental setting. So what are the downsides then of this approach? Because it seems like it's a no-brainer. It seems like it should be done. It should, this should be the end of the presentation. We all take this away and that's the end of it. But there must be some downsides. So the first thing is we don't know whether this idea of screening for diabetes in a dental setting is deliverable at scale. And I was really heartened to see the statistics from Promosalud that this may be the case. But in the healthcare setting that I work in the National Health Service, where budgets are tight from a governmental point of view, we don't know whether we can then put that additional burden on the healthcare system, because the extra screening will come at a cost. The extra screening will come at a cost to the dentist or hygienist or nurse who's doing the screening. It'll then come at a secondary cost to the general practitioner who's managing the diabetes if it's diagnosed, etc., etc., etc. So we don't know whether this is deliverable at scale, which then goes into funding models. How is this funded? And different healthcare settings have different funding models. And I can only speak in earnest about the National Health Service where I work in the UK. So funding these programs is a key thing. It is possible that the benefits gained from screening early, diagnosing early, and managing early yield so much benefit in the long-term management of someone that money is saved enough to allow for the screening, but we don't have that data yet. The other downside is, well, how do we screen for diabetes? We could use a questionnaire, but the questionnaire needs to be validated in the populations that you're screening for. We can do point of care testing, like I said, a finger prick test where you get you may have seen those already, a drop of blood, and you put it on a filter paper and it gives you a reading. So those are point of care testings. But those are not as accurate as we'd like them to be. In the hospital, we use a machine from Siemens called SEPA-DENTAID, which is probably the best, but it's very expensive. Also, in your healthcare setting, you need to check with your professional indemnity or regulator if you're indemnified, if you're insured as a healthcare professional to screen for diabetes. And I know in the UK that isn't the case routinely, that it's beyond our scope of practice. It seems like a no-brainer, and I know a lot of dentists, and myself included, who are comfortable screening for diabetes in a dental setting because the benefits are so great and the risks are so low that we are happy to accept those risks. But if you're a little bit more risk averse, then you may want to check with your indemnity or regulator whether you're allowed to do this in a dental setting. And as I mentioned earlier, the gap from screening to diagnosis to management to the actual benefits being realized is not known. So we can say, yes, we've screened 100 patients, but we may find that of those 100 patients screened, only 80% then followed up with their dentist or with their doctor. Of those 80%, then only 40% had a formal diagnosis and only 20% had the right management, right? So the actual benefits take time to accrue, and we don't have those studies yet that tell us the benefits of the long-term benefits of screening for diabetes in a dental setting. If we had that data, then the economic case becomes really easy to make. You can say, look, by screening early, we've saved the healthcare £10,000 because the patient didn't have these complications. Therefore, we can spend some of that £10,000 that we've saved in the screening process itself, but we don't have that data to make that argument. And again, like I said earlier, this is a question of screening. This is a question of capturing different population in different settings. So you should also think about screening in non-dental settings. So screening in pharmacies, screening in supermarkets, barbershops, screening in opticians, screening in other settings, ideally healthcare settings. So pharmacists and opticians make more sense, but even in non-healthcare settings, it's important that screening is done, because the 40% of patients who don't know they have diabetes are not in the dental setting alone. So I'm going to end with a few practical tips about what you can do as clinicians to help your patients in this journey. So the first thing is, how can you spot that someone maybe has undiagnosed diabetes? So you're in your clinic on Monday and your patient comes in through the door. What signs and symptoms could you look out for that tell you that someone may be undiagnosed diabetic? So the first thing is bad periodontitis. And again, if you've had enough experience, then you will recognize what this is. This is someone who has this really, boggy gingiva, really swollen gums. Oral hygiene is generally okay, not too bad, but the level of inflammation is not in keeping with their oral hygiene levels or their risk factors. So that's one thing that, as dentists, hygienists, periodontists, we'll pick up on. The other thing is that your patient may have a dry mouth, and with this may come a fissured tongue. So you may have intraoral manifestations of diabetes. Your patients will also be more prone to infections, fungal infections like candidal infections, and lateral periodontal abscesses. And this is sort of alarm bells kind of moment. If your patient has multiple lateral periodontal abscesses, you should recommend that they see their doctor for a diabetes check if that's the only thing you do. I'll go through some other things that you can do, but multiple lateral periodontal abscesses is big alarm bells going off. Okay. So what questions should you ask if you do suspect that someone may have diabetes? And these are called the 4 T's of diabetes. The first T is toilet. So do they go to the toilet quite often? Do they have frequent urination? Do they get up at night to urinate? Okay. This is coupled with increased thirst. So polyuria is going to the frequent urination, and polydipsia is a lot of thirst. You're quite thirsty. So polyuria and polydipsia are both features of diabetes, uncontrolled diabetes or undiagnosed diabetes. Then your patients may be tired. That's the third T of diabetes. If they're feeling tired, or they don't have any reason. I've got a 2-year-old daughter at the moment, so I've got lots of reasons to be tired. So there are other reasons for being tired. But this is not one of those. This is someone who's just tired. And then they're getting thinner without meaning to get thinner. So their weight is falling off and they don't mean for it to happen. Okay? So these are the 4 T's of diabetes. So you can ask these questions to your patients, which then may trigger another level of management, another level of risk. So you thought, okay, from my oral examination, I think this person may have diabetes. I've asked them these questions, and they do get up to go to the toilet quite a lot at night. They do have thirst, they're feeling tired, etc., etc., etc. So what should you do next? So you should inform the patient that you're really asking these questions because you're worried that the patient may have diabetes. You can tell them that from your oral examination, this is what you found and this is what you suspect, but now you want to see if there's anything else. You've asked your questions for 4 T's. You can ask about family history of diabetes. So, do your parents have diabetes? First-degree relatives, do they have diabetes? Then ask about second-degree relatives. So uncles, aunts, grandparents, those kinds of things. Any family history of diabetes. Then you can go through formal questionnaires, and the QR code here is for the FINRISK questionnaire, which Eduardo will be familiar with because he's done some work with this in a Spanish population. So I'm pleased to say that this is validated in a Spanish population. But that's also the important thing about questionnaires. The questionnaire that you administer needs to be the validated version in the population that you're administering it. So you can't just take a questionnaire that's been used in one population and automatically apply it to a different population. So just make sure if you are doing this, the questionnaire is validated in the population that you're using it. You can use point of care tests, and a lot of practices now in the UK will have a point of care test machine. We'll have that in case of medical emergencies. In any case, if you have a medical emergency, you want to make sure that someone isn't hypoglycemic. So we'll have, as part of our emergency drug kit, a blood glucose monitor, but a lot of practices are now investing in point of care test for HbA1c. And if you remember the difference between HbA1c and blood glucose is blood glucose will fluctuate and HbA1c will stay more stable. So it'll give you a better representation of medium-term glucose control. Once you've done all these things, then your job as healthcare professionals in a dental setting is to refer the patient on for formal tests with their doctor and then management with their doctor. So we don't come up with a diagnosis in the dental clinic. We certainly don't come up with a management in the dental clinic. So that is all then a communication that needs to be had with the dentist and the medic. The medic will manage the patient's diabetes, diagnose the patient's diabetes. And it's not as easy as, one point of care test reading that means you have diabetes. No, you need 2 separate readings a time apart before you know you have diabetes. So there's a little bit of a disconnect between positive screening and an actual diagnosis. So how do you treat patients who have diabetes? So you inform them if they don't have periodontitis already, you inform them that they're at a higher risk of periodontitis. So their oral care needs to be amazing for them to mitigate that risk. You'll screen for periodontitis like you do for all of your patients. And then if you find periodontitis, then that's managed in the same way that you would for all of your patients. So again, the management of periodontitis isn't different because someone has diabetes. The only thing that may be different is that you'll warn patient about the need for maintenance, the need for improved oral care, the need for improved risk factor control in their particular case, also to do with diabetes control. So that is the only tailoring of the periodontal management, is the risk factor management. Brilliant. And with that, I've come to the end. So I'd like to thank my mentors, Professor Dietrich's on the left, and he should have been the one talking here. So, I'm glad you get to see him. And to the right is Professor Chappell, my funder, the National Institute for Health Research, my amazing medical and dental colleagues, and Ajit, Mia, and Lara, my family. And thank you all for listening.
Thanks for your presentation, Dr. Sharma, Praveen. A real pleasure always to listen to you. And as we are, como vamos un poco justos de tiempo, vamos a dar paso ya al siguiente ponente.
As you know, we're not doing very well in terms of time, so I'm going to give the floor to the next speaker. Miguel Carasol is going to introduce Antonio Lorente. Miguel? Thank you, Edu. But you know what? I would not want to miss the opportunity of thanking Praveen Plus.
And the conclusion for me is we need you. It's very important for us, this presentation and your concept about diabetes and periodontal disease. Bien, dicho esto, thank you so much.
Okay, gracias.
Voy a presentar al siguiente ponente, que es el doctor Antonio Lorente. ¿Por qué?
And I'm going to introduce the next speaker, Dr. Antonio Lorente. Why? Because you're going to think, okay, everything you told us about the high blood pressure, about diabetes is very good. Really, it has scientific evidence. That's why we're talking about that. Otherwise, we would be talking about something else. And now what we want to do is that we want to challenge ourselves, ask ourselves, well, doing Promosalud, Promo Health in the dental office, is it very costly? Is it a mess? Do we need to set up an intensive care unit or what? Not really. It's easy. It's extremely easy. Actually, Dr. Antonio Lorente is going to tell us. Why? Because Antonio Lorente, apart from being a doctor in surgery and medicine at the Complutense University of Madrid, apart from being a dentist at the European University of Madrid and being a master's program in periodontics at the University of Madrid, because he's been a professor of radiology and periodontology in the two universities that I've told you about, he is a golden medal in scientific merit. He is a phenomenon. And he is the manager of a office which is called Class Center that has contributed with most patients to the Promosalud project. So he started many years before developing Promosalud. He started to understand as a doctor the importance of screening patients with diabetes and high blood pressure on dental offices. I followed him, and that is really why he is an exceptional communicator, and he's going to share with us his experience, which is really nice, because there's not many patients that say no to this screening and prevention concept. So thank you so much. Antonio, you have the floor. Thank you. Thank you, Miguel. Can you hear me? Yes, can you hear me? Good. Thank you. Thank you very much for the presentation. It's clear that you're a good friend. The only thing I want to tell you is seeing how knowledgeable all of them are. I'm just going to tell you that I'm very happy to have implemented in an easy manner this big initiative promoted by SEPA-DENTAID. I'm going to try to share with you quickly, so as not to take too long, how to use Promosalud in your dental office. The first thing you need to do is that you need to enroll, obviously.
Hay que
que no estoy compartiendo.
You're not sharing your screen. Oh, yes.
Espera, perdona un segundito. A ver. Mira que lo tenía preparado. Sí, sí, a compartir. Lo tengo.
Allow me to share my screen.
Esperar. A ver, que no quiere unirse ahora.
Creo que solo le tienes que dar a la presentación, al keynote, Miguel. O sea, porque
Sí.
ya estamos viendo tu pantalla, pero
A
estamos
ver.
viendo como eso, ya solo le das a reproducir y ya está.
Vale.
Y ahora,
Perfecto. Gracias,
eso, ahí.
Edu. Venga, pues es tan fácil como
It's so
entrar en la
easy
página web de
that you just
Promosalud
need to
y
enter
darse de alta,
Promosalud
¿de acuerdo?
website and enroll.
Una vez rellenamos
Register,
este
and
formulario de
once
alta,
you
nos hay que inscribir los
fill in
datos de la
this
clínica y del
enrollment
responsable odontológico de la
form,
clínica,
as the
mandamos
person in
los
charge of
datos
the dental office, you
y a
just
continuación
register, send the data,
recibiremos un
and then you
usuario y
will
una
get a
contraseña para
user
poder
and a
entrar
password
en la
in
plataforma.
order to be able to access the
Nosotros en la
platform.
clínica tenemos un iPad
In our dental
en el
office, we have an
que
iPad where
es en el que vamos a ir
we
introduciendo los datos porque
enter the data.
a pie del sillón es muy cómodo entrar en
It's
la
more
plataforma y
convenient
empezar
to
a
enter the
registrar todos
platform
los datos.
chair
Bueno, pues
side
una vez
to register the
estamos dados de
data.
alta,
Well, once we
podemos
have been registered,
clicar en el acceso a
we can
clínicas,
click access to dental
introducir
offices.
nuestro
We can enter
usuario
our user code
y contraseña y acceder. Esta contraseña que
and
nos
our
envía
password and
posteriormente, una vez que estemos dentro de la
access.
aplicación,
Once you get the
podemos
password,
cambiarla a
obviously,
nuestro
once you
antojo
are
para
registered, you can obviously
que ahora
personalize it,
mismo
change
son
it
tantas
afterwards.
contraseñas.
There's so many
Yo, si
passwords
no las tengo
nowadays that
apuntadas,
unless I
pues
write them
para
down,
recordarlas,
I'm not going to be able
poder
to
recordarla con facilidad,
remember
podemos
them.
cambiarla.
And we can then
Una vez que
obviously
estamos
change them.
dentro, podemos
Once
dar
we're
de alta
inside, we can
a nuestro paciente.
register
La
our
aplicación
patients. The app
inmediatamente
immediately
genera un registro
generates
en el
a
que va a haber
record
fundamentalmente dos partes.
where there's going to be two
Una primera
parts.
parte que va a
The first
corresponder
part is going to
al
be
código de la clínica
the code of
y
the office,
una
and
segunda parte
the
que
second
va a
part is
corresponder
going to
a
be
cada paciente. Con lo cual,
for
con este
every
código
patient. So with
podemos
this
saber,
code, we
podrá
can
saber
know
en la aplicación
in
a qué
the app
clínica
what
se está
office
refiriendo y
this refers to
a qué paciente, porque
and what
posteriormente
patient, because
podemos
afterwards we're
registrar,
going to be
como
able
ya
to
os
register, as I
indicaré,
will tell you,
diferentes
different
registros. Una vez se ha generado
records.
este
Once this
código,
code has
lo
been
único que hay que hacer
generated,
es
you just need to
introducir el
introduce the
género
gender
y la fecha de
and the birth
nacimiento del
date of the
paciente.
patient,
Y con eso
date of
entramos
birth.
a hacer el
And by
registro
doing this, we
de
just
todos
register
los
all of
parámetros
the
que
parameters
vamos a
that we are
intentar
going to try to
recabar.
gather.
Lo primero van a ser
First,
lo primero el registro metabólico, ¿vale? Una
metabolic
serie de preguntas que
registry.
están
There's some questions
fundamentadas en el
based
FINRISC, que como ya han
on
indicado
the
es
fin
un
risk, which
registro
is, as has
muy
already been said, a
contrastado y que es muy
proven
fiable y
registry,
además muy
easy
sencillo
to
de
use
utilizar,
also.
¿vale? En ello vamos a ver
And
si
we're going to
realiza
see
deportes,
whether they
qué tipo de
do
dieta tiene,
sports, the type of diet
si es su
they
historial
have,
familiar o
the
si
family
a él
record,
mismo le han dicho que alguna vez ha tenido
whether they've ever been told that they
el
have
azúcar alto. Y a
high
continuación empezamos a registrar otros
sugar,
parámetros, como son el
and some
peso
other
y la
parameters
talla.
such as weight
Nosotros en
and
la clínica
height.
tenemos una balanza y
We
un
have a
pedímetro, que
balance
son
and
dos utensilios
a measurement of height,
baratísimos,
which are
incluso
very, very
los
cheap
tenemos en el
both,
cuarto de
and
baño
we even
justo
have
ahí
them
en
in
el
the
seguimiento. Pero
toilet,
muchas veces
especially the weight balance,
nosotros
not
muy
the
raro
height
la persona que no sabe
measurement.
cuánto pesa y cuánto mide,
Most of the
con lo cual
people know
también
how much
se
they
podría
weight and
simplificar de esa
what's their
forma, pero
height.
siempre
It
va a
would
ser
be
mucho más
easier,
fiable
but
tomarlos
it's
los
always
datos
going to be more
sobre todo
reliable
para
to take
registrarlos.
the data so that
Y
we can
yo desde
register
luego
them.
en todos los
I
años
myself,
que
in all
llevo
of the
realizando
years that I've been doing this
esta historia clínica, incluso
clinical
antes de
record,
Promosalud,
even
nadie le ha
before I
importado
was part of
pesarse ni
Promosalud,
tallarse.
nobody
Se hace
minded
siempre, además lo podemos
me
utilizar como un chascarrillo, ¿no? Para
measuring them under height, under weight. You can also joke it to decrease the stress with the patient. And the app, once you enter these parameters, tell us immediately what is the body mass index. And you just add that to the record of the patient. The next thing, the perimeter, just on the umbilicum, the abdominal girth is just going to be one more parameter. We have an additional parameter, glycated hemoglobin, that we could detect with detectors, such as glucometers, with just a little bit of blood. It's going to tell us, and very often what we do is, well, we do a full analytic, a blood test, but you don't need to get to that level. And we tend to ask them whether they have some recent blood analysis or blood test that they've got in some other type of medical doctor. And the majority of our patients have one. Unfortunately, the majority don't have glycated hemoglobin, but yes, in many cases, we've been able to detect it. Well, we've taken it to the extreme and we ask for a full blood test, but asking for an old blood test can be a very easy thing. And immediately, even if we have not introduced glycated hemoglobin, we've entered the, we're going to record, register all of that in the record, in the patient record. What else? Well, blood pressure. It is important to do different readings because there's a hypertension, which is the white coat hypertension. Just by telling them that you're going to measure the blood test, blood pressure tends to go up. So the first record is not good enough normally. But as soon as we take one record after a certain amount of minutes, the blood pressure normally goes down. And then we take again the measure between the second and the third measurement, which is the most reliable one. We always recommend to use tablecloth blood testers, which most of them, the tabletop blood pressure monitors, such as whether there's arrhythmias or changes of the heart rate, that we can also register. The wrist blood pressure monitors tend not to be so reliable. We don't advise them. So once we have all of this data, in further appointments, later appointments, we can check them again. Because if in some of these assessments, appraisals, we get values which are outside of the norm, it's very useful in different appointments to take new records to see what's the evolution of the patient. The personal experience, and I'll tell you later with a video how important this is. With all of this data, the app generates reports, 2 reports actually. What are these reports going to be used for? If we see some changes in the values, we can tell if we see these changes in the patient's values, we need to tell them. We're not going to diagnose, we're just going to do a screening, and in this screening we can see changes. And what's the easiest way is to tell the patient? Well, by referring the patient. As soon as we get the results, if we see some changes, we generate that report that we give to the patient so that they give it to their doctors, who will be in charge of doing the diagnosis of the disease, be it diabetes or hypertension. And in that report generated by the app, you will see the blood pressure measurements, the body mass index, the abdominal perimeter, the result of the film risk, and in case we took also the glycated hemoglobin also, the value and other remarks. This report is printed in a PDF and we give it to the patient together with another report in white so that their general practitioner or their family doctor, once they've done the tests and the diagnosis, but might be normal, absolutely no disorders, so that they send it back to us so that we keep them in record. And maybe the patient was nervous and maybe that was why that day they had the higher blood pressure, or maybe they had some problems that caused the sugar to be high. The fact that glycated hemoglobin is high without having diabetes is more strange. But anyway, the tests need to be done by the doctor so that the doctor diagnoses the diseases, if there are diseases. And that we will tell the patient to give it to the patient, to the doctor, and also back from their specialist or from their family doctor back to us. What is the advantage of Promosalud for us health professionals? It is an added value for our dental office, I think. There's a study in the Journal Public of Health Dentistry that analyzed all of this, and they saw the attitude of patients in front of this type of studies, and 94% of them considered that this screening was important. How does the attitude change in professionals of the office? That increases the knowledge, the know-how, the professionality of the people. So patients perceive that their health professionals are not only interested in their teeth, but also on their health. And that is very, very good for us. They perceive us as a better. That is a differentiating element vis-a-vis our competitors. Although I don't like to talk about competitors, but rather the population of dental offices that we have around us, with whom, by the way, I collaborate very often. So I have a video here to show you how patients perceive the metabolic study that we do with them.
No se oye, Antonio.
Ay, perdonar. No
Antonio, we cannot hear the video. Oh, sorry. How can I share the sound of the video?
Porque yo
Because
sí
I
lo
can
oigo.
hear it myself. When you shared the screen, you should have pressed the little button that told share audio also. So if you want us to listen to the video, you need to share again, and you will see a button that says share audio. Stop sharing. Exit. Okay. Share again, and you will see to the right button that says sharing sound.
Cuando le das otra vez a compartir.
So when here we go. There we go. Yes, you're right.
Me pide una contraseña, Mario.
Oh,
no sé.
Mario, they asked for a password. I don't know what I did. I'm so sorry.
A ver, ¿y ahora?
Vale.
¿Ya?
Cierra la puerta, que estoy ahí.
Vemos tu pantalla.
¿Ya lo veis? Vale, fenomenal. Ven, a ver si ahora...
Sí, perfecto.
¿Lo escucháis? ¿Lo escucháis ahora? A ver, perdona.
¿Escuchar? No sé.
I don't know.
¿Se escucha ya?
No.
No.
Se te está viendo como en slow motion. No.
Bueno, pues ¿qué le vamos a hacer?
Bueno, el paciente, perdonadme, ¿vale? El paciente lo que nos está explicando en el vídeo es que os voy a ir transcribiendo un poquito, ¿vale?
And I'll tell you what we talk about. I'm going to tell you.
Pues que no le ha llamado mucho la atención.
He says, well, I didn't find it surprising, really. I thought in principle that was due to the fact that I was going to anesthetize him, but really After explaining him the reason why we did it, he found it very interesting, the fact that we found or looked for relationship with other diseases that he could have. And since they go more often to doctors, rather to dentists than to general doctors, he found that it was a good way to look for possible disorders of health in general.
Dice que hacía mucho que no iba a su
He said
médico de
that
cabecera
he had not gone to his general doctor for a long, long time, and that he found it strange
por saber cómo
that
tenía
we
la
concerned
tensión
about the fact that he had the blood pressure
cuál
right,
era su dieta.
and the fact that we asked about the diet.
Muy bien.
Bueno, la cuestión es
Anyway,
que,
well,
en definitiva, los
to sum up,
y
patients,
esto es una experiencia que Miguel y yo hemos vivido, les llama
according
mucho
to
la
Miguel
atención,
and myself,
pero no
find
solo
it
eso, sino
striking
que
not only that,
una
but
vez
also
que hemos
the fact that
detectado,
once
como
we've
nos pasó
detected,
con un hipertenso en el Ruber,
as
no
it
sé si
happened
lo
to us
recuerdas,
in
Miguel,
Ruber, I don't know if you remember,
el
Miguel, with
tensiómetro
a
saltó
hypertense
con una luz
person,
roja,
where the
y directamente
red
le dijimos que
light
saliese de la consulta y entró en
jumped
urgencias,
in
y le
the
diagnosticaron una hipertensión. Poco después, cuando vino a su revisión periodontal,
blood
no
pressure
hizo más que
monitor was
darnos las
used.
gracias
He was
por
diagnosed
haber
afterwards, and little
detectado
afterwards he
esta
came back to
tensión.
us
Tenía más de
to
200
thank us
y le
because he
preguntamos si le
was
dolía la
over
cabeza o
200.
algo,
We asked him,
y
do
él
you have
nunca le había
headaches? And
dolido
he had
nada,
never
pero
had headaches.
si nosotros no
But
hubiésemos
had we
detectado
not
esa
detected
hipertensión,
that
bueno, y la
hypertension,
hubiesen diagnosticado correctamente,
had he not been
probablemente
diagnosed
esto hubiese
correctly,
debutado con
probably he
algún
would have had some stroke
accidente
sometime
cerebrovascular que podría haberle causado grandes problemas. Y lo
with
mismo
big
nos ha pasado
problems.
con los prediabéticos. Una
And
vez que les
pre-diabetics, it's the
hemos
same.
advertido
Once
de
we've
que
warned
tenían
them
ese problema,
that they have that problem,
nos han agradecido
they've
y en la
come to
consulta cada
thank
vez
us.
me cruzo con alguno de ellos.
And every time I see
Qué
some
bien
of them
estoy,
in
doctor.
the office, they say, I'm so
Alegría
happy with you, doctor.
que nos hiciese esas pruebas,
I'm so glad
porque
you
gracias a
made
eso
those
ya estoy
tests.
haciendo una
Thanks to
dieta
that,
y
I'm
tengo la
following
glucosa
a diet.
normalizada.
My glucose is
Yo
normalized.
espero que viendo cómo aplicamos nosotros
I hope
Promosalud en la
that
consulta, os animéis muchos
the
más
fact
a
that we've
hacerlo
shared with you the way
y
we use
que
Promosalud in
veáis que
our office
realmente
encourages you to
es
do
muy
so,
útil y que
and you will
estamos
see.
detectando,
I hope
eso
that it is
Eduardo
really very useful.
es un
And
experto
Eduardo is an
que nos podrá
expert on
decir
this,
cuántos
and he will be able to
enfermos
tell you how many
silentes se han
silent
detectado ya con este trabajo.
patients have been
Espero
detected
que ahora
with
nos lo
Promosalud. I
cuente para
hope he
que lo
tells
tengamos
us
arriba y
soon so
podamos
that we're very happy
seguir empujando de esa manera. ¿Vale? Pues espero
and
haberos
continue
aclarado las cosas y muchas
working
gracias
on
por
that.
haberme invitado a este
Thank
elenco
you very much
de
for inviting me
científicos
to this
sabios en el que me habéis incluido.
group of
Muchas gracias.
wonderful
Muchas gracias,
panelists that you've included
Antonio.
me.
La verdad es
Thank you
que es
so
un
much,
placer
Antonio. It
para
is a
nosotros
great pleasure
invitarte
not
aquí,
only
sino
to just
participar
invite you, but
durante
also
tantos años contigo en este
to have worked
proyecto
with you in this project
que
for
está muy
many
bien.
years now. It's nice. It's really nice.
Que además
Also,
yo creo que tiene la relevancia de que llevamos muchos
it's
años
relevant because for many
sin que los
years now,
pacientes se nieguen a hacerlo. Y
our
esto yo
patients
pues
have
es
been
una cosa que
accepting
creo
doing
que
this,
debemos comentar
and
con los
we need
demás.
to
Es decir,
tell the
la
rest.
gente pensará, los dentistas
People might
pensarán,
think, some dentists might think,
¿qué
wow,
pensará mi paciente? Se
my
pensará que voy a
patients are not
quitar el
going to
dinero, que no sé qué, tal,
want me
tal.
to do that. They're going
Es decir,
to
es
think that I
una
want to
cuestión de
rip them off.
preocuparte
Not
por su salud
really.
general,
They consider
es una
that
cuestión de
we are
preocuparte por
worrying about their
ser
general
mejor que
health,
los
that
demás,
we want
y
to be
esto es
better
así.
doctors,
Es
better
decir, es
health
ofrecer un
professionals.
servicio
Actually,
que
that's the
otros no
case.
ofrecen,
We
pero es
offer services that others don't
digamos,
offer, but it is somehow
favorecer el
a way
que
of
te puede salvar vidas en una
saving
consulta.
lives
Además, me
in
gusta mucho
our offices.
el tema y yo creo que esto es muy, muy relevante,
And
que
I found something very, very
llevar a cabo
relevant, which is
Promosalud en
that
una consulta dental
implementing
no es una cuestión
Promosalud
del
in a dental
dentista,
office
es
is
una
not a
cuestión de su
thing
equipo.
that the dentists
En
have to
primer
do,
lugar,
but rather the
aquí
entire
tú tienes la
team
enorme
can do
suerte de
it.
tener una
You're
higienista como
lucky
Cristina
because you have a
Navarro,
hygienist
que
who
es
is
capaz
wonderful,
de llevar
Cristina
a cabo
Navarro, who
Promosalud
can
con
also
todos los pacientes que
carry
tiene.
out
Pero
Promosalud with
yo animo
all
a
of the
todos los
patients, but
demás
I
a
would
que formen
encourage the
equipo,
rest to
porque
train
ya
their
sabéis que es una
team
cuestión muy simple,
because
muy
it's simple,
sencilla
it's
y demanda
easy.
poquito tiempo.
It
Y
doesn't
yo
take
creo que es
much
muy, muy
time.
relevante.
It is very,
Muy
very
satisfecho
relevant. Thank you,
¿vale?
Antonio, so
Y
much.
ahora cedo la palabra.
Gracias a vosotros.
Thank you.
Muchas gracias.
Thank you. And I'm going to give the floor to Dr. Eduardo Montero, who is going to introduce us Dr. Mario Narce. We're not doing well in terms of time, but it's a very interesting topic. We need to insist. And thank you really for being here. She's going to talk about something that Eduardo Montero is going to present, which is fundamental. It's one more step in the good work of dentists. Edu is going to introduce Marion. Marion, thank you so much for being with us. Thank you, Miguel. Thank you, Antonio, for your presentation. It's very relevant to explain people how we do this and how patients live and perceive it. Thank you. Let's go ahead. We're not doing very well in terms of time, but it's okay. Dr. Mario Narte is going to talk about something very important, how to promote healthy life habits in the dental office. We do Promosalud not just to identify patients who suffer from high blood pressure or diabetes or may at least have the risk of developing that, but we can also do something about it. We don't diagnose, but we can provide advice to promote healthy lifestyle, diet, exercise, which is good for anyone. No matter if they do that in the barber shop or in the supermarket, as Dr. Eva Martina Aguilera said. So Dr. Mario Narte is a professor of periodontology in Chile University in Santiago and a specialist in periodontics. She got an award from the Institutology Foundation. So she was in Madrid Complutense University for 1 year working with our research group. And she's done research in different fields, periodontal medicine. She's an expert also in ethiopathogenia of periodontitis and inflammatory host response to bacteria challenge. It is a luxury to have her with us. Marion, we give you the floor without further ado. Thank you. For the invitation.
Lo vemos adecuadamente. Muchas gracias.
Can you see the presentation? Yes, we do.
Okay. Bueno, buenas tardes a todos y a
Good
todos.
afternoon to everyone. First of all, I would like to thank Eduardo and SEPA for inviting me to be part of this very interesting symposium that we are working on. Well, we are learning about many strategies and tools to promote oral and general health to prevent pathologies, systemic pathologies that have been presented by previous speakers in detail, which are related to oral pathologies. I'm going to tell you in 15 minutes about the promotion of healthy lifestyle habits in the dental office. We need to ask ourselves, what do we mean by habits? When we think about a habit, what is a habit? A habit is a behavior that is repeated regularly and that with time will become natural or automatic. We won't need to be motivated to behave like that. It's going to become a daily routine, a weekly or monthly routine. For instance, if I want to carry out an activity, for instance, something I decided when I was invited to be part of this symposium, I thought, okay, this is to promote healthy lifestyle, so we need to set the example, right? And I decided to carry out some physical activity, specifically something to move my body for a few days, and I decided to do yoga. Maybe you can drink 2 liters of water a day or read a book, different types of activity that may help us have a healthy life. What do? We repeat day by day, every 2 weeks, week by week, month by month, until there comes a time when I do not need to encourage myself to carry out this activity, to be able to behave like this, but rather I'm just going to learn the behavior. It's already learned, and I will do automatically in the daily routine. We all have different habits. Some of them are healthy, some of them are not. For instance, my grandmother had a habit, I don't know if it was very healthy, which was drinking 1 glass of wine every day She said it was for her health. So you get some habits and you acquire habits throughout your life. Some of these we've learned from the time when we were little, some of the habits we've learned throughout life, and some of the habits we ourselves decide to carry out, or some of them are habits that we are told that we need to learn somehow when we are adults. So this is a learned behavior, something that I can decide to do and I can learn how to do. Now, how long does it take to acquire a habit? I don't know about you, but I had the idea, I don't know why. When I asked myself, I thought 21 days. Somewhere I had read 21 days is the amount of days it takes you to create a habit. And yes, there's an idea. Some people say that 21 days are enough for a habit, and this comes from a book written in 1960 by a surgeon, a plastic surgeon, who assessed how many days it took for his patients to get used to their new appearance after the surgery. But this was related to getting used to something new rather than to creating a habit per se. But in 2010, there was a study published made in London where 96 volunteers participated, and this study used a tool which is a habit tracker, which is delivered to the patients, saying, for instance, what you need to do is eating one piece of fruit every food, or drinking 2 liters of water every day, or 15 minutes of exercise before dinner. They delivered this habit tracker, and you write in the site the habit you want to get, and during the 30 days, and in this case the study was longer, they evaluated whether they did or not that action during the day. So they had to fill in every day the habit tracker, if they did the habit or not. They monitored. What they got from this study was the following result. They got a range of habit creation into automation, something that was more automatic without having to take decision to do anything. It takes between 18 and 258 days. That's a wide range, with an average of 66 days that it takes to create a habit. And this difference is related to the amount or the type of habit we want to create in our patients. Now we know it's a habit. Now we know the amount of time that it takes normally to create a habit. The question is, which are the healthy life habits? The World Health Organization published some years ago, which are the 7 healthy life habits that we should all comply with. Let's see if we all comply with them. Make a tick in each one of them. First, healthy food. That's the first thing and the most important thing in order to have a healthy life. Aerobic exercise of at least 150 minutes a week. Something that we should all do. We need to sleep between 7 and 9 hours a day. I know it's difficult, obviously. Having a good hygiene, including showers, wash hands, and oral hygiene. And we play a very important role in the oral health, especially. Avoiding smoking, no alcohol, or other bad substances, and weight control of each one of us, each one of our patients. That is also part of this Promo Health strategy. And finally, but also very important, our mental health. We need every week and every day to dedicate some time for our self-care, leisure time, doing something for our mental health. Sometimes also go to psychological therapy that give very important tools to have a better mental health, especially in the times we're living nowadays. But in our offices, in our dental offices, Do we promote really healthy life habits according to the World WHO? Yes, we do. We do health promotion, basically oral health. We show our patients how to keep and maintain a good oral health, which is one of the healthy life habits promoted by the WHO. And this is very important. Not only do we tell our patients brush your teeth twice a day and use interdental floss, rather we need to allow us for having the necessary amount of time for each one of our patients, because different oral hygiene techniques have to be individualized. We need to explain to them how to do that. Not only that, but also we need to in on the next session and the next one and the next one and modify it if they're not good. When we show, when we teach oral hygiene techniques, we have to modify a habit that they've learned for many years, and that's more difficult. So we need to not only show once, but show once and again, so that the patients can have a better control of the main etiologic factor, which is the biofilm. Not only that, but we also promote the types of healthy life habits. In periodontics, we do, at least in the step 1 of the clinic guidelines. One of the very important things that we need to do is the control of systemic factors. And we've seen in previous presentations that it's very relevant to control pathologies for the success also of our therapies. So we do, with this strategy, screening. We also do referrals. Tomorrow, by the way, it's the World Day of Anti-Smoking, and we also do anti-smoking counseling. How do we do that? Well, to all of our patients, not only to those who smoke. Not only because they smoke, does it mean that if they don't smoke, they're not under the risk of smoking? In Chile, at least, the Ministry of Health gives us practical advice for a brief anti-smoking counseling. It just takes you 5 minutes. And the first thing is to obviously ask the patient if they smoke or not. If they do not smoke, they have never smoked, we need to congratulate them. It is always important for habit creation to do positive reinforcement also in oral hygiene when patients come, and when we strengthen the general hygiene, we say we're doing fine, but let's modify whatever. Always a positive strengthening in the habit change is very relevant for the perception of the patient to see how they decide to do this more easily. So we need to congratulate our patients if they don't smoke. We need to tell them, fine, go on like this. And if they're former smokers especially, and we need to ask former smokers. I'm at the university and you can hear some people laughing. My colleagues are having lunch. Anyway, I'm sorry if you hear noise. If our patients don't smoke, if they're former smokers, what we will do is that we will congratulate them and we will ask them, do you need help, assistance, in order to continue non-smoking? To stay like that, because we want to prevent not going back to smoke. If they don't smoke, then we, yes, need to take more actions. We need to ask, when did they start smoking? How much they smoke? How long does it take them to start the first cigarette from the time they wake up? Do you know about the risks of smoking? And do you know the benefits? And there's different counsels that you can give to the patients depending on the motivation of about whether they want to smoke or not, because the final question is, do you want to stop, to quit smoking? Because if they want to quit, we can give them counseling to help our patients, and if they don't, we also need to give them information, certain information that is impactful. For instance, 78 hours after you quit smoking, your high blood pressure goes down, you improve your taste, your smelling, you won't have so many wrinkles and so on. Presently, on the other hand, we have a very big, wonderful initiative by SETA that invites us not only to promote oral hygiene habits, but also doing an anamnesis and more detailed records in the detection of systemic pathologies. And obviously also, we need to start educating our patients, and also we need to promote all the healthy lifestyle habits that we normally don't. For instance, we can educate them in thinking that all chronic pathologies have a common relationship, which is the systemic inflammatory process, as we saw initially. Can we do anything else as dentists from our position in the dental office? Oh, yes, we can. Yes, we can always do more things. We can help create healthy life habits. We can, for instance, use this type of tools that were used in this study of habit creation, that are habit trackers, where we can do the following. We can give them this habit tracker according to the WHO, telling them, fill them in at home to see if you comply with these habits. And in the next appointment, we can see whether they really comply with healthy lifestyle or not. We can reinforce positively those who don't do it, and we can take actions if the patients really wanted that to improve here in this type of duty. And in order to do that, depending on the case, depending on the need, we can also work in a multidisciplinary team with all of the health team that we have available, not only in our clinical team in the office, but having our kinesiologists, having our nutritionist, our doctor, our psychologist that we're close to, so as to generate an international network to treat these patients in a multidisciplinary way. This is about time to stop being isolated from the rest of our health team. The mouth is just part of our body. What happens in the mouth has an influence on the rest of the body and the other way around. That's been proven. We need to be able to make sure of that. And we as health professionals, which is what we are after all, we need to promote health to prevent diseases rather than treating pathologies. Otherwise, we should call ourselves the professionals of disease, but we're called health professionals precisely because we need to promote health to prevent diseases. And it's up to us to educate and to promote these healthy life habits from each one of our places, such as, for instance, in the dental office. And that's about it. Thank you all once again for inviting me to participate in this very interesting symposium. If you want to contact me, these are my contacts, and thank you very much for everything. I hope I didn't take too long. No, it was okay. Mario, thank you so much. Marion, for your very interesting presentation. And if Miguel agrees, we will just go to the end, which is the presentation of the results, right? Oh, yes, yes. But first, I'd like to thank Dr. Marion Arce for her participation in our Promosalud project and in this symposium. We're not doing well in terms of time, but these are very important things, and for the health of our patients, we consider that time is always something that we need to dedicate. Habits are very, very important, and in our dental offices, we consider that they are more and more relevant, and we need to talk about them. Thank you, Marion. And now we just have the final thing to do. Well, this is Promosalud. This is fine to do that, but do we have any results? What is it that we're doing? What have we done? What is it that we're going to be doing with the results of Promosalud? And here we have Dr. Eduardo Montero, who is wonderful. He's going to present all of the data. He has a degree in dentistry. He has a master's program in periodontology at the Complutense University of Madrid. And this has been corroborated supported by the Federation of Periodontics, the European one. He's a PhD in dentistry with an international mention, and he's an extraordinary award of PhD. He's fantastic. He's also an associate professor of periodontology, and he's presently the secretary of the working group of SEPA with the Spanish Society of Diabetes. He's the coordinator of Alliance for Periodontal and General Health of SEPA. What we call Alliance for Health, we call the community of the ring. We love it. We're working with Eva and with many others, actually. And he is in charge of Promosalud right now. So he's the best person to tell us about how we're doing with the results in Promosalud. Thank you, Eduardo. Thank you, Miguel. Thank you for the introduction, your kind introduction. I'm going to share my screen, number one.
Decirme solo, confirmadme si veis bien la presentación.
Can you see the presentation? Yes. Good, thank you. Thank you, Miguel, as you said, for the introduction. It's a pleasure for me to be here today. Miguel and myself have been working for many years on this project. Even before it was called Promosalud, it had different names. Miguel has always been a very important person in the mentality change as dentists, because we need to go beyond the oral cavity of our patients. And him, but Antonio also have been working in his office as a model of what we want to export to initially the network of research offices of SEPA. Then the study was called Risk, and then all of those offices that wanted to join this Promosalud initiative, because after all, what this is all about is that the public health is going to benefit from us dentists being more and more a part of health and not a part of disease, as Dr. Mario Narde said. I love that. We have the skills, obviously, because we get the training in our university degree, but we need to implement those skills. I'm going to present to you the results that we've got up to date. We have very positive results, as we've been told recently. The number of dental offices is large, and the number of patients is huge, 901 patients. Maybe now there's even a bit more. And these results are very interesting to us, I think. I'm going to very, very briefly refer to Promosalud and the objective.
Pero sí que voy a hacer un poquito referencia a alguna cuestión de las que hemos analizado que quizás hemos hecho mención un poquito más de pasada, ¿no? Y es que nosotros básicamente esto del cribado de la diabetes o prediabetes.
When we talk about the diabetes and the pre-diabetes, hypoglycemia and hypertension, on the other hand, is not just about this. We want diabetic patients to prevent complications related to diabetes, mostly cardiovascular diseases, as
de mortalidad en el mundo, ¿no? Y por eso a partir de los parámetros que registramos
So from the parameters we register in Promosalud, we can also calculate what we call score function. Score function is a score that tells us the risk of death for cardiovascular reasons in the next 10 years. Systematic coronary risk evaluation. It is related to the Framingham assessment in Boston, in Framingham, from the 60s. There's a study of cohorts that have been carried out in a big population to identify the risk factors of the cardiovascular diseases. That is one of the reasons why we know that smoking is one risk factor for cardiovascular disease, and cholesterol also, too. But when this algorithm was used in other populations different from the American ones, such as, for instance, the European populations, for different reasons, basically related to some characteristics of the population, it didn't work so much. It didn't predict so well the cardiovascular disease. Specifically in the States, the prevalence of obesity is higher, and so on. So they developed a risk function for Europe, which is called SCORE, Systematic Coronary Risk Evaluation, with some reference or benchmark categories, and depending on whether you're a smoker, whether you're a man or a woman, the blood pressure and the cholesterol, and so it tells you for how much you experiment your risk of by dying due to cardiovascular disease in the next 10 years. And so if it's under 10%, it's low risk. If they are over 1 or between 1 and 5, it's low risk, and so on. This is one leg, so to say. The other leg is, in the case of Promosalud, it's very important with this questionnaire that is called find risk. In the find risk study, we use a tablet to determine the glycosylated glycemia, yes. In no cases we can do the diagnosis, but if we just want to establish whether the patient can have diabetes or pre-diabetes and maybe not know it, or whether they're running the risk of developing it in the near future, which is what this questionnaire tells us, well, maybe with the questionnaire it's enough, and it also does not interfere much on first appointment in the dental office, up to such an extent that myself in the office, when we give them the tablet so that they fill in their medical record and their previous dental record and so on, they fill in the questionnaire, and when they send them to me, I can take a look at the find risk. In the majority of the cases, they don't have a very high risk, but in some cases when they have the risk, you can use it as a guide to ask more other questions. Maybe, if necessary, we can even promote, yes, healthy life habits from the very beginning. This makes sense because they're very prevalent diseases, and 50% of the population don't know that they suffer from those two diseases. So yes, it's very relevant. What's the objective of all of this? Well, doing the screening of these pathologies, but also we wanted to go beyond there. Does this have any relationship with the periodontal status? If they have periodontitis, if they have more advanced ways of disease, do they have more cardiometabolic risk, diabetes without knowing, hypertension and not knowing it? Yes. Well, we want to group all of this in the protocol of assessment of low cardiometabolic risk patients, Promosalud, that's it. From the very beginning, Promosalud wanted to not only disseminate the information, but also to do research. Our idea is for all of these analyses, obviously, to be published finally. Let's hope that they actually are soon published. That's one of the reasons of this project also. What's the design of the study? Well, this is an observational cross-cutting study. It's an easy design. When you do a design where potentially you can have 2,000 dental offices, you can imagine that the protocol is not very strict. The study population is the same. What are the candidate patients? Any patient who goes to a dental office. We personally don't include patients who are immunosuppressed, for instance, under treatment with chemotherapy, or transplanted patients with suppressants, and pregnant women, because when it comes to assessing the evaluation between the periodontal situation and the possibility of them having hypertension or diabetes, maybe that could interfere in the assessment of that association. How is the protocol? Well, you've already seen it very briefly. So as not to repeat myself, we have a clinical record, we fill in the find risk, and we determine the blood pressure, and initially the glycosylated hemoglobin, not anymore, but as part of the find risk, we include a determination of the abdominal wrist perimeter and determine therefore whether they are obese or not. Based on these variables, including cholesterol, also we can establish the function of a score. And finally, all of these patients are going to be subject to a periodontal exploration, which is just going to be a basic periodontal checkup, a screening to assess the periodontal treatment needs. This basic periodontal test is similar to the FETETIN, the index that shows whether we need to treat or not, is assessing not only the pockets, but also the attachment loss. And if we have pockets of more than 3 or 4 millimeters, then and only then we do a periodontal chart. And then the confirmation diagnosis, we won't be able to do it, so we just send a note for the patient to take to the doctor so that finally we get the confirmation report afterwards. But at least we can give data about what we record: cardiovascular, fine risk, periodontal, or rather blood pressure that we measure in the office. And also if we determine glycosylated hemoglobin. We calculated the size of the sample. Considering the prevalence, we considered it as a moderate or high or very high score in Spain, which is around 20%. It's not low, by the way. We're always proud of our lifestyle in the south of Spain, the Mediterranean diet, and so on, right? Well, really, our cardiovascular risk is not that good. It's not better than other patients in other countries of our environment, and we needed a patient of at least 300 patients. The analysis you're going to see now, the preliminary analysis we've done on 901 patients. So we've certainly gone much more beyond than the initial 300, and at some point in time we will have to stop in order to publish it. But anyway, 950 patients approximately have been assessed to be included in this project, but some of them were discarded for different reasons: pregnant patients or patients who didn't want to participate just. So we ended up with these 901 patients with a prevalence slightly higher of women, and the average size is approximately 60. And what are the characteristics of the sample? Basically, what is it that we're measuring in the score, the systemic coronary risk evolution and the periodontal situation? Well, we were capable of identifying patients with a score which was equal or higher than 10% in 2.5% of the population. As for the blood pressure, we identified that 40% of patients who came to the dental office had values of blood pressure which is compatible to hypertension diagnosis. And in this case, maybe Eva, correct me if I'm wrong later. Maybe we will have time later for questions or debate. But in the case of hypertension, yes, we can determine in a reliable way in the dental office. And with respect to glycosylated hemoglobin,
no veo las diapositivas, perdonadme. Y en lo que respecta a los valores de la hemoglobina glicosilada, pues como veis, casi un 10% de los pacientes que incluimos
almost 2% of the patients that we had in Promosalud had glycosylated values, hemoglobin, similar to diabetes and prediabetes, hypoglycemia, 20%. So this is relevant. We tend to say diabetes has a prevalence of 13%, 6% of them have not been diagnosed. Well, really, what happens in patients who demand treatment of a dentist, considering that the glycosylated hemoglobin devices overestimate this slightly, that's important. This is a screening, this is not a diagnosis, but look at the data that are shown by our research. And if we consider the fine risk questionnaire, this is consistent, because if we group together the scores of a moderate to high risk or high, 40% of the population, approximately, similar to high blood pressure, 40% have a high risk of having diabetes and maybe not knowing it or developing diabetes in the near future. And when we saw the factors associated to a high score and HbA compatible with diabetes and with high blood pressure, I'm going to tell you which were the significant values for each one of these parameters and variables. In the case of a score, it was the age, obviously, and the smoking habits. It was part of the function, obviously. Cholesterol, systolic and diastolic blood pressure, glycosylated hemoglobin, and fine risk. They all helped determine that the patients who have the risk of having diabetes and maybe not having it also have a high risk of cardiometabolic diseases. So everything related to diabetes is something interesting to us because of the complications that are associated. When we talk about glycosylated hemoglobin, it's similar. Age, obviously, it's a risk indicator, which is important for diabetes in this specific case. And as you know, especially because of the important relationship between type 2 diabetes and obesity, obesity is always defined from the body mass index. This was an important parameter, and the abdominal perimeter in men and women. Abdominal fat is the one which is really bad for both men and women. And with respect to high blood pressure, it's similar. Age, gender, body mass index, abdominal perimeter in women, fine risk, and a score, obviously, as should be expected. What happens when we pay attention to variables, periodontal variables? The periodontal basic score, bleeding edge, bleeding percentage, bleeding depth of more than 4 or more than 6, average, non-clinical attachment, and so on. In the case of a score, there is a clear correlation between the code that the patient has according to the basic periodontal chart, basically related to the pockets. Inflammation also, bleeding on probing is important. And in the case of glycosylated hemoglobin, it's compatible with pre-diabetes and diabetes diagnosis. We have bleeding on probing and percentage of sites with a pocket depth of at least 4 millimeters or maybe more. And in the case of high blood pressure, we instead were not capable in our sample as compared to other publications from other countries. SEPA, for instance, in our sample, we did not find periodontal variables a correlation with high blood pressure. We identified high blood pressure in 40% of our patients, and 40% of our patients obviously did not have advanced ways of periodontitis. So, not even in those who come for dental treatment. And to summarize, look at this. The important percentage, if we group together the score, the high or very high score, the important percentage of the population that has a risk of mortality rate because of cardiovascular disease during 10 years, 20% basically, there's a very big percentage of patients who might have pre-diabetes and diabetes, hyperglycemia, therefore, whether they know it or not, because in this research we included patients with diabetes. We did not exclude them as compared to what we did with the fine risk. The objective was to know whether these tools allows us to screen those patients who did not know whether they had diabetes, if they knew that they were excluded in other. And if we compare this to other publications, well, with respect to cardiovascular development, there is a research by Madeleine Cocho in the Netherlands, where the results are aligned. And John Telanglick also, they reflected difference with periodontal explorations of patients with periodontitis and those without periodontitis, and they were able to identify that actually the cardiovascular disease was much higher in patients with periodontitis, 20% approximately, as compared to others who did not have periodontitis. Now, if we talk about glycosylated hemoglobin, maybe the main reference was the seminal research of part of this project of Promosalud, which was the study by diabetes risk. Within the network of research clinics of SEPA, we went from the Complutense University of Madrid, the ones that coordinated that research, but in this study, the prevalence of prediabetes and diabetes, which is not diagnosed, that we identified is much lower. But I'd like to remind you two things. Number one, in Promosalud, we only included patients with diabetes and prediabetes and who knew that. And number two, in the case of a diabetes risk study, we did have a confirmation diagnosis. That is to say, these values that you can see, 6 and 2.5%, are not consistent with what we were told by code of care tells of high glycosylated hemoglobin, but rather based on the diagnosis of reception of their primary care doctor or their endocrine,
Claro, como decíamos, lo que sí que es importante,
the confirmation of
desde luego no es lo
the
porque también
diagnosis.
nos viene a
So
dar valor, ¿no? Como periodoncistas, es que
we as
realmente existe
periodontologists consider that it is important to know
asociación
that there's an
muy
association,
clara y
a
manifiesta
clear one,
entre el hecho de
between the
presentar
fact
una peor
that
situación
having a
periodontal
worse periodontal
genera
status
una mayor
generates
probabilidad de
a
presentar
higher
unas
probability
formas
of
mejor,
having a higher
una
score,
función de riesgo cardiovascular más elevada. Fijaros, por
a
ejemplo,
higher
cuando
systemic
tenemos
coronary
scores
risk
por
evaluation.
debajo del
Look, when we have
5%,
scores
¿de
of
acuerdo?
under
Pues casi
5%,
todos los pacientes con
most of the
EPBs
patients
1 o
were
2, ¿de acuerdo? Pero sin embargo,
EPB
cuando ya
1,
empezamos a
2,
tener,
or
¿de
3,
acuerdo?
but when we have
A encontrarnos EPBs de 3 o 4, estaríamos
EPBs
hablando
of
de un
4 and
porcentaje
5, we have a
además
percentage
relevante,
which is more and more
aumentable
relevant
todavía, por supuesto, ¿de acuerdo? De pacientes que presentan
of
un riesgo
patients that have
cardiovascular
a
moderado
cardiovascular
o
risk which
elevado,
is moderate or high.
¿vale? Así que, bueno, todo viene un
Okay,
poquito
so
a resaltar la relevancia, ¿de
this all
acuerdo?
underlines how
De
relevant it is.
este proyecto, ¿de acuerdo? Sobre todo, como
Uh,
comentaba Antonio, es decir, es muy bien
this
recibido
project is
por los
very
pacientes. Creo que
important,
es
and
incluso,
actually
en
the
último
patients,
término,
as
bueno,
Antonio said,
también puede,
love
por
it.
supuesto, permitirnos sentirnos
They
quizás más
accept
realizados
it,
dentro
and we feel
de nuestra
better
profesión. Incluso es un
as
factor diferenciador
professionals.
entre aquellos
It's a
dentistas, ¿de
differentiating
acuerdo? Que
factor
ven más allá de
with
la
other
cavidad
dentists
dental, ¿de acuerdo? Y que
because we
transmiten esto,
see
precisamente esos
beyond the oral
cuidados,
cavity,
esa
and that's
preocupación
something that
real
we really
a los
convey to our
pacientes.
patients, that
No es
we
algo que
really
realmente sea
are
muy
worried
time
about the
consuming, por decirlo
health.
así, sino que
It's not
es un
really
protocolo
so
rápido y
much
mínimamente
time
invasivo.
consuming. It's
Incluso si lo
quite
quieres
fast. It's
simplificar en
minimally
tener que
invasive. And if you want
recurrir
to
a estos
simplify,
dispositivos
if
de
you
determinación
don't
de
want to
glicada,
use
colesterol,
these
etcétera, todavía es más
glycated
sencillo,
cholesterol
simplemente
devices,
llenando
it's going to be even more
cuestionarios
simple
y
just
el
by
coste es muy
using
bajo. Por
questionnaires, and the
supuesto que
cost is so
claramente,
low.
¿de acuerdo?
It's a
Cuando nosotros
cost
lo
which is
hicimos
really low.
estimándolo a partir de
When
los
we did it
fungibles que
estimating
se
with
usan para estos
fungibles,
dispositivos y demás,
the
fijaos que
disposable
cuando lo realizas
things that are used,
los
well,
cuestionarios, pues todavía es mucho más bajo el coste
if
que se
you
desprende de
don't
la
use them,
aplicación
if you just
de
use
esta
the
diéresis
questionnaires, it's even
periodontal,
going to be
¿vale?
cheaper.
Así que como conclusión que
So
podemos
as a conclusion,
presentar en este momento, ¿de acuerdo? Pues
for
teníamos
you right now,
un
number
porcentaje de
one,
pacientes 2,5 con un riesgo muy
2.5
alto
of patients
de
have
mortalidad por
been
causa cardiovascular en un periodo de 10 años. Si nos
detected as
íbamos a alto y muy alto,
death
pues
risk
era
by
prácticamente por encima del radar
cardiovascular
del 20%. Teníamos
causes,
esta
which is very
publicación de
high,
pacientes que presentaban valores
more than
propios
10%,
de
and
hemoglobina glicosílada
9.4 of
compatibles
patients
con el
with
conocimiento
levels
de
of
diabetes mellitus y sobre todo somos capaces de
HbA1c
identificar
compatible
un
with the
síndrome de
presence
colesterol, a
of
diferencia de lo que
diabetes
ocurre, por
mellitus,
ejemplo,
more
pues
than
con
6%.
valores
We've observed an
incluso
association
que puede
of
tener la situación
a
periodontal
worse
con el hecho de presentar
periodontal
un peor
status and a worse
estado cardiovascular,
cardiometabolic
tanto en lo que
status
respecta al riesgo
shown
cardiovascular en general
in a
como
higher
la
risk of
hiperglucemia en
cardiovascular
particular,
death
¿no?
and high
Con
levels
esto
of HbA1c.
termino, he hecho una presentación
And
muy
that's
breve
it.
para poder
I
acceder a
made
las
a very
referencias que
brief
hemos
presentation so
presentado
that
en esta presentación,
I
en
could
el
show
código
you
QR, que
the
quisierais
bibliography
quisierais
that you
escanear, ¿de acuerdo? Podéis
that you
echarle un
will be able
vistazo
to
y yo creo
access
que
if
con
you
esto
want
hemos hecho una
with
muy
this
buena
QR
revisión un
code.
poco de lo que son
Well,
los resultados hasta la fecha
this was
de
the
Promosalud.
about the
Creo
results
que
of
esto es muy
Promosalud
positivo
up to
para
now.
Miguel,
I
yo
think that
sabía
this
que
is
empezaba a compartir
probably
con él
new even
por
for
distintos
Miguel. I don't
medios,
know if
así
I'd
que
already shared
bueno,
it with
quizás
you, Miguel.
aunque vamos
Anyway,
con un poquito de retraso, a lo mejor
we
5
delayed
minutillos
maybe 5 minutes of
de
questions
debate o incluso de preguntas
or
para la audiencia, en
Q&A.
caso de que nos hagan llegar alguna, podemos tener.
Pues muchas gracias, Eduardo, por
Thank you,
ocultarme la verdad.
Eduardo.
Gran sorpresa, Miguel. Es decir, todo esto
La sorpresa
había que
siempre
prepararlo
es
para el último
positivo.
momento.
Bien, muchísimas gracias. La verdad que ha
Thank
sido
you.
una
Thank you
presentación
so much.
fantástica. Yo
It was
creo
a fantastic presentation. I think
después de estar mucho tiempo
that after
discutiendo sobre el tema
being
de Promosalud
for a
y
long,
hemos
long
pasado
time
por
talking
todo
about
tiempo, pero veo
Promosalud,
que
and
hay
we
muchos
took a lot
valientes
of
que
time, but
todavía
there's many
siguen
people who are still
asistiendo, aguantando a nuestra presentación.
there.
Entonces, muchas gracias, Eduardo. La verdad que
So
como
thank you so
siempre
much.
es fantástica tu presentación. Muchas gracias a
Thank
todos
you so
los
much, Eduardo. Thank you so
participantes,
much for your
especialmente
presentation. Thank you
Marion.
to all the
Gracias
participants, especially Marion. Thank you
Praveen. La verdad es que
so much,
han sido
Praveen.
unas presentaciones
These
fantásticas.
presentations have been
Antonio,
wonderful.
Patricia,
Antonio,
todos, en
Patricia,
definitivo.
all
Bien,
of you.
yo creo que de alguna manera la conclusión final que debemos sacar es
I
que
think the final conclusion that we
los
can reach is
dentistas, yo
that
soy médico,
dentists, and I'm a
pero
doctor,
creo que los dentistas
but
debemos
dentists,
involucrar, y dentista, y
I'm
los
a doctor
dentistas
and a
debemos
dentist, and
involucrarnos
we
mucho
doctors and we
en la
dentists
salud
need
general
to
de los
get
pacientes, porque es
engaged in
nuestra
the healthcare
responsabilidad
of our
y
patients.
porque
It's
no
our
lo tenemos en nuestra
responsibility.
casita. Antonio
And
nos lo
it's
ha comentado,
easy.
es decir,
Antonio has told us. This is cheap, this is simple, and it doesn't take much time, and it allows us to save lives. So I think that somehow it's important for us to little by little make dentists aware of the fact, and hygienists and teams, assistants, aware of the importance that this is very, very relevant to enjoy these benefits, which is saving lives after all. If this is not a benefit, well, let's come and judge it, because most probably it's the best benefit that we can have. Obviously, we save mouths. We can do it very well, but if we save lives, it's even better. And it's a very simple mechanism. As Antonio said, they're all based in scientific evidence, which is extremely important. So we won't be limiting ourselves. We are not inventing anything. We're just basing ourselves on very serious, rigorous studies that allow us to somehow make sure that what we're doing and that we're going to be doing, we're doing well. So I would encourage you all all of you dentists, and I know that there's some foreigners who are listening to us from outside of Spain, and they're thanking us, and we're thanking them, obviously, for their involvement and for being here, so that amongst all of us build a system that benefits our patients, which is our objective after all, our biggest goal, our biggest effectiveness. That's all. Thank you all. And in any case, we'd just like to close this event. And next week, we also have another event in Mexico, Eduardo and myself, to present. Yes. It's part of our dissemination task to the other side of the Atlantic, in Mexico, with colleagues. Yes, we're going to talk to Elon Musk to promote it maybe in Mars. It's still a little bit far away. I don't know if he's in a time of being very receptive. Most probably this is not his best time. But anyway, thank you so much. It was a pleasure. Thank you. Thank you. Thank you. Bye.
¿Qué es Promosalud? Promosalud ofrece recomendaciones de aplicación en la clínica dental para la detección precoz del riesgo de padecer diabetes o hipertensión arterial. En España, 17 millones de personas padecen hipertensión arterial y 5 diabetes. Prácticamente la mitad de estos pacientes no están diagnosticados. La consulta dental es un espacio sanitario que recibe la visita del 60% de la población al menos una vez al año. Esto confiere a la asistencia odontológica el potencial para mejorar la calidad de vida mediante la promoción de la salud bucal y general, contribuyendo así al Objetivo 3 de Salud y Bienestar promulgado por Naciones Unidas dentro de los Objetivos del Desarrollo Sostenible marcados en la Agenda 2030. Los objetivos de Promosalud son 3. 1. Prevenir, diagnosticar y tratar las enfermedades periodontales de los pacientes. 2. Sensibilizar a la sociedad de la importancia de la periodontitis como indicador de riesgo de la diabetes mellitus o enfermedades cardiovasculares. 3. Detectar el riesgo de padecer prediabetes, diabetes mellitus o hipertensión en las personas que reciben atención odontológica en las consultas dentales. La Fundación SEPA pone a disposición de las 23.500 clínicas dentales españolas Promosalud una herramienta de aplicación clínica que, bajo la dirección del dentista, permitirá al equipo de salud bucal contribuir a mejorar la calidad de vida de la población. SEPA, periodoncia y salud bucal para todos.